A very good morning to one and all. Now, I invite Mrs. Nirmala M.O., Nursing Superintendent, SCT IMST, to welcome all of you. Ma'am, over to you.
Good morning, all. Let me start with a word of gratitude to our respected director, Professor Dr. Sanjay Bihari, who has given the permission to conduct this webinar on nursing updates in heart failure by the Department of Cardiology, Nursing Service Division, SCT MST, and in association with the Heart Failure Association of India. Heart failure is a major cause of morbidity and mortality, and it causes significant impairment in the quality of life of patients with those who are affected. So heart failure, the management of these patients require a comprehensive team approach, including the doctors, the nurses, social workers, psychologists, dietitian, everything. So nurses are also an important part of this comprehensive team. So if they have to provide a quality care and comprehensive care to these patients, their knowledge and skill has to be improved and it should be updated. That is the importance of conducting this webinar. So my duty is to invite all of you for this event. First, let me invite our director, Professor Dr. Sanjay Bihari. Sir, even though he was, since a few months only he was here, he shows all interest and enthusiasm in all the activities of the nursing service division, especially the academic activities, and in spite of the patient care activities. Let me welcome Sir wholeheartedly on behalf of nursing service division and on behalf of this webinar. Welcome, sir. Then the first session of this meeting will be chaired by Dr. B.K. Chopra. He is the professor in director Cardiac Sciences, Senior Director, Cardiac Sciences, Max Hospital, New Delhi, and he is a founder, director, and president of Heart Failure Association of India. And Dr. B.K. Ajit Kumar, professor in cardiology. He is a former director of SCT MST and now the dean of the SCT MST. Sir, both of you are welcomed to this webinar on behalf of this meeting and on behalf of the Nursing Service Division. Then Dr. Sandeep Seth, professor in cardiology, All India Institute of Medical Sciences, New Delhi, and Dr. Krishnamurthy KM, the HOD, Cardiology Department, SCT MST. So both of you are welcome to this meeting on behalf of this meeting and the Nursing Service Division. Then Dr. Hari Krishnan, he was behind this webinar and he has given all the guidance and instructions in selecting the topic as well as preparing the slide. Throughout the preparation of this webinar, he has helped us along with the Dr. Sanjay, professor in cardiology. Sir, welcome you, sir. Then other faculty members, senior residents, other doctors, nursing officers, and all those who are connected to this webinar are welcomed to this webinar on behalf of Nursing Service Division. Once again, I welcome all of you. Thank you.
Thank you, ma'am. Distinguished participants, may I now request Dr. Sanjay Bihari, Director of SCT IMST, to inaugurate and address our esteemed participants of the webinar. Due to his busy schedules, he could not join live with us. Let's play the recorded speech.
Good morning. I congratulate the nursing staff of Sri Chitra Tirunal Institute for Medical Sciences and Technology, as well as all the other participating nursing staff for organizing the nursing update in heart failure. I'm also grateful to the Heart Failure Association of India for kindly sponsoring and for promoting this wonderful event. I think focus on heart failure is a very, very important thing. This is simply because there is no other condition where a constant clinical, medical, physiotherapy, as well as psychological focus is required for the patient. And not only that, even common activities of daily living, like for example, if some person takes a long walk, or if some person has a common cough or cold, then this is enough to precipitate pulmonary edema, dyspnea, and other issues associated with heart failure. And I'm so glad that in this conference, several important issues are being addressed. They include epidemiology, how this whole spectrum of heart failure is focused in the surrounding areas and how we can deal with it, how we can focus on cluster areas where we can actually provide treatment, the pathophysiology, the various neurological deficits and the signs and symptoms to make people aware of what is going on. And then I'm also very happy that case presentations are being done so that the actual focus is being taken care of. And the final point is that the behavioral aspects and patient-related education is also being addressed. This represents a very comprehensive focus on heart failure, and the role of nurses in this entire endeavor is a very important one. I congratulate all the nursing staff for organizing this wonderful event, and I'm also very hopeful that this will be extremely educative for everyone who participates in it. I wish this program a grand success. Thank you very much.
Thank you, sir. The learned participants, may I now request Dr. Hari Krishnan, Professor of Cardiology, SCT IMST, the master brain behind this webinar, to give an introduction to this webinar. Sir, please.
Good morning, ladies and gentlemen. So heart failure is now an emerging epidemic, and it is eating into the healthcare budget of both developing and developed economies. So in the last few years, we have many therapies which have been found to be significantly beneficial in patients. Now we have, when we were students, we had only diuretic, and when we were, if you answer a beta blocker for heart failure, we will fail. From that situation, beta blocker has now become one of the 4 pillars of therapy. So now we have the 4 pillars of therapy in heart failure with reduced ejection fraction. And we now have a therapy for heart failure with preserved ejection fraction in the form of SGLT2 inhibitors, the wonderful anti-diabetic drug. Also, there was no significant data on heart failure from India. We have now multiple registries, which like the Trivandrum Heart Failure Registry, the Kerala Heart Failure Registry, and the National Heart Failure Registry, where we have reported the short and long-term outcomes of heart failure. All those show that the mortality, the short-term and the long-term mortality is significantly higher in the Indian population. Our patients are 10 to 15 years younger, and the 5-year mortality, as reported from the Trivandrum Heart Failure Registry, is in the tune of around 59%. So 2/3 of the patients we are losing at 5 years. So this mortality is actually higher than many common cancers like breast or colon. So we have to consider heart failure as a major public health problem and address it. So how to address the problem of heart failure? So what we have found from these registries is that the guideline-directed therapy. The guideline-directed therapy is the one which reduces mortality. For example, the 4 pillars of management of the drugs which we have to prescribe, the exercise program which we have to advise the patients, the diet and salt restriction which we have to advise. All this will improve the outcome. So only 25 to 40% of the patients in India are getting these guideline-directed therapies. So our aim is to improve the guideline-directed therapy and increase it to the maximum possible levels. Heart Failure Association of India, our motto is to improve heart failure care. So we are organizing many programs to improve the heart failure care in India. We do physician education programs, short physician education courses of 6 weeks with the help of European Society of Cardiology and Heart Failure Society of America. We also have conducted multiple nursing education programs, short courses with the help of Trained Nurses Association of India. And we feel that all this will help in improving the heart failure care and improve the outcome of patients with heart failure in India. So in this background, we organized this webinar aiming at nursing staff, and our nursing superintendent has said the nurses also play a part, but I should correct that. It is that nurses play a very important part, and I think the most important part in the management of patients with heart failure, because heart failure nurse is a very important component of heart failure care in the West. I think we also should go in that line, because in the busy schedule, the physicians may not be able to provide the counseling and the ensuring the drug compliance in these patients. I think heart failure nurses can play a very important role. And Heart Failure Association of India is planning to develop and run courses to train heart failure nurses to tackle this problem of the lack of heart failure nurses in India. So with this background, I invite the next chairpersons to the session, and I hope that this program which we have designed will help in understanding about the guideline directed therapy, and will improve the understanding among the nursing staff how to improve the heart failure care and how to improve the outcomes of heart failure patients in India. Thank you so much.
Thank you, sir. Let's move on to the scientific session. For the first session, we have two leading cardiologists of the country to chair the session. Dr. Ajit Kumar, former director of the IMST, as well as the dean of our institution, and he is very pleased with academic activities. Welcome, sir. Dr. P.P. Chopra, senior director, cardiac sciences, Max Hospital, Delhi, has been elected to chair the session, and he is one of the board of governors of Failure Association. Welcome, sir. Now we move on to the first session on heart failure in India, epidemiology and common causes. I invite Mrs. Tesmo Anthony, nursing officer, comprehensive heart failure ICU, to deliver the presentation.
Good morning, everybody. Is the audio clear? Is it?
Yeah. Your audio is clear, sir. The audio from the hospital has some issues. Sir, please, before starting now, Ajit sir, please introduce the topic and.
Yeah. Good morning, everybody. I think on behalf of of Sri Chitra and the Department of Cardiology, I welcome all of you to this important session on heart failure. Now, it is quite impressive that that Dr. Hari Krishnan, who's taken the lead on heart failure, has actually brought this system of organized activity in the division of heart failure. For any organized activity in the division of in any higher aspects of cardiology, you need some certain aspects. You need a combination of the consultants, you need a combination of researchers, the nursing staff, and the field staff for an organized activity. And this is a typical example of how he has formed this division into its full-fledged form. And this is an example of how the nursing group, which actually deals with and is an important component of heart failure, has taken this matter up. Now, coming to the topic, so I should congratulate the group for having taken the lead of having organized this nursing symposium on heart failure. Now, the topic is on, so we will come to the scientific aspect of the discussion. And the discussion is primarily on the heart failure, the epidemiology, the pathogenesis, and the management. What we will do is that we can have 12 minutes of discussion and 3 minutes of talk. Professor Chopra can take on. So you're muted. Yeah.
12 minutes of talk and 3 minutes of discussion.
Yeah. So I think we'll invite the first speaker for this session, that is heart failure in India, epidemiology and common causes.
Epidemiology and common causes. Introduction. Epidemiological data on heart failure in India are recently emerging. A few hospital-based cohort studies provides information regarding in-hospital and early outcomes of patients admitted with acute heart failure, while long-term outcomes are recently published. In India, Trivandrum Heart Failure Registry, Kerala Heart Failure Registry, and National Heart Failure Registry have recruited 1,205, 7,512, 10,850 patients accordingly, and published data on inpatient, in-hospital, 90-day, 1 year, 3 year, and 5 years outcome on heart failure. failure, an emerging epidemic. The burden of heart failure is rising in both developed and developing world. Heart failure accounts for healthcare resource and significant mortality. 1 to 2% of healthcare resources are channeled toward heart failure, and a 1-year mortality more than 30%, and 5-year mortality of 50 to 60%, which is higher than many common cancers. Universal definition of heart failure. The proposed universal definition describes heart failure as a clinical syndrome with symptoms and or signs caused by a structural and or functional cardiac abnormality and corroborated by elevated natriuretic peptide levels and or objective evidence of pulmonary or systemic congestion. The classification of heart failure according to left ventricular ejection fraction now includes heart failure with a reduced ejection fraction, symptomatic heart failure with left ventricular ejection fraction less than or equal to 40%, heart failure with the mid-range ejection fraction, symptomatic heart failure with the left ventricular ejection fraction 41 to 49%, and heart failure with the preserved ejection fraction, symptomatic heart failure with the left ventricular ejection fraction greater than or equal to 50%, heart failure with the improved ejection fraction, symptomatic heart failure with a baseline left ventricular ejection fraction less than or equal to 40%, a greater than or equal to 10-point increase from the baseline left ventricular ejection fraction, and a second measurement of left ventricular ejection fraction greater than 40%. Etiology of heart failure, Indian perspective. Data sets from Trivandrum Heart Failure Registry, National Heart Failure Registry, and Inter-CHF Registry. The major contributors to heart failure in India are coronary artery disease, 72%, and dilated cardiomyopathy, 9%, valvular heart disease, rheumatic, 6%, and non-rheumatic, 2%. The minor contributors are hypertrophic and restrictive cardiomyopathy, includes amyloidosis and sarcoidosis, endomyocardial fibrosis, arrhythmia-induced cardiomyopathy, congenital heart disease, Eisenmenger syndrome, hypertension, cor pulmonale, and pulmonary artery hypertension. Risk factors and comorbidities are hypertension 49%, diabetes mellitus 44%, alcohol 17%, tobacco usage 33%, and atrial fibrillation 11%. And based on the National Heart Failure, Trivandrum Heart Failure, and Kerala Heart Failure Registries, the heart failure with reduced ejection fraction is more prevalent in Indian setting. That is, around 2/3 of the patients are affected with the heart failure with reduced ejection fraction. In NHFR, it is 66%, and Trivandrum Heart Failure Registry, it is 62%. Kerala Heart Failure Registry, it is 67%. Compared to US data, it is only 46%. Comparison of epidemiological profile of Indian and Western patients with heart failure. The age of the Indian population affected with heart failure are 56 to 64 years, compared to the Western data of 69 to 73 years. 10 to 15 years younger patients are affected in our country, and there is a male predominance of 70% in Indian population. The disease burden in patients less than 65 years is 60% in Indian data, 30% in Western data. The disease burden in patients with more than 85 years is 4% in Indian data and 25% in Western data. According to heart failure types, heart failure with reduced ejection fraction contributes around 65%, but in Western data, it is only 50%. The heart failure with the preserved ejection fraction, Indian data, it is only 12%. Western data, it is 40%. The higher prevalence of heart failure with the preserved ejection fraction in Western data. The heart failure with mid-range ejection fraction is 22% in Indian data, and in Western data, it is only 10%. Indian data, ischemic heart disease contributes around 73%, but in Western data, 50%. More ischemic etiology in Indian data. And dilated cardiomyopathy accounts for 17%, and in Western data, it is around 16%. Rheumatic heart disease, which is unique to India, contributes 6% in Indian data, and non-rheumatic heart valve diseases contributes 2.5% in India and 5% in Western data. Mortality trends in Trivandrum Heart Failure Registry are 1 year, it is 30.8, and UK National Heart Failure Authority data contributes around 32%, and in 3 years, 44.8%, and 5 years, it is 58.8%. In Trivandrum Heart Failure Registry, the patients received device therapy usages are very low, and guideline-directed medical therapy, 25 to 40% of the patients received GDMT. The readmissions are there are 50 to 50.41% of with no rehospitalization, and 69.22% with more than one rehospitalization. Readmissions in heart failure indicate a higher risk patient, which impacts on hospital resources and high mortality. 30% in Trivandrum Heart Failure Registry, that is 333 patients readmitted. Of them, 80% admitted once and 20% more than once. 80% readmitted with heart failure exacerbation alone. The burden of heart failure in India likely to be high, and patients are predominantly male, around 70%, and younger by 10 to 15 years. Heart failure with a reduced ejection fraction is 65%. Heart failure with a preserved ejection fraction is only 15 to 20%. Lower prevalence versus Western data. Ischemic heart disease, dilated cardiomyopathy, and rheumatic heart disease accounts for 90% of heart failure in India. Short-term and long-term mortality is higher in India, and guideline-directed therapy improves outcome, but only 25 to 40% receives the treatment. The quality improvement initiatives are necessary in our country. Thank you.
Thank you for that lecture, which certainly has a lot of clarity and a lot of information. Quite impressed with this talk. I think there are certain very important aspects which have been noted, which requires some discussion. Specifically the difference between the Western and the Indian data. If I just would take one point to start off so that the discussion happens. So if you look at heart failure with preserved ejection fraction, which is fairly low represented in the Indian context. But then some of the studies have shown, even in the Indian, when people have looked for in much greater detail, a much very higher prevalence. I think it must be related to under evaluating or under assessing the actual prevalence of heart failure with preserved ejection, which is likely to go up. So I think the statistics will after some time will have a similar pattern in both the Western and the Indian. Dr. Chopra, please.
So I agree with you, Dr. Ajit, but I feel that actually the heart failure with reduced ejection fraction is a lot more common in our country. And the reasons are fairly obvious. We have a very large population of young MIs who today there is a widespread availability of CCUs, thrombolytic therapy, primary PTCA. So these people get salvaged and then they're left with damaged ventricles, which contributes to heart failure with reduced ejection fraction later on. And also we know that in our population, the coronary artery disease and other diseases also start at least 10 years younger. The proof of that comes also from various clinical trials of heart failure with preserved ejection fraction that were conducted in our country in several centers. Despite trying very hard, looking at interacting with pulmonologists, with general physicians, it is hard to get heart failure with preserved ejection fraction patients as opposed to reduced ejection fraction patients. There is no doubt that a lot of them are getting missed. They're going to pulmonologists and so on and so forth. Because in our country, unfortunately, an EF of 55% in many minds translates into no heart failure, which is not true. So I think it is a mixture of both the things. And also the male preponderance, which was mentioned in the slides, it is not a true male preponderance. Unfortunately, in our society, women don't get as much healthcare as do men. So I think the actual incidence in women also would be very much significant. Besides, we are a diabetes capital of the country, which of course contributes to both the conditions, reduced and preserved. The longevity in our population is not as much as that in the Western population. And HFpEF is, the incidence goes up much more as we age. So I think it is a multiple factors. And as you rightly mentioned, the true incidence will come up when we have more refined, methods of finding out from our population the true HFpEF population. Thank you.
Dr. Hari, what do you say on the matter of mortality, which is very high Is this related to the disease pattern, its issues, or is it related to treatment-related issues which result in mortality which is higher in our economies or in our geographies, let's say?
Yeah, there are multiple factors, sir. For example, if you take, because 70% of the heart failure is due to ischemic heart disease. So what we have found is the door to balloon time or door to needle time and the time of presentation to the hospital. So the symptom onset to the presentation is 4.4 to 6 hours in the Indian settings. So that itself is a significant delay in the treatment of MIs and all. So that contributes significantly to the heart failure burden. The second is the guideline directed therapy. In the Trivandrum Heart Failure Registry, it was 25% when we did it in 2013. In the National Heart Failure Registry, when we did it in 2019-20, it improved to 40%. There is a significant improvement. But still, 40% of the patients with heart failure with reduced ejection fraction only receive the guideline directed therapy of 3 drugs, like ACE inhibitor or plus beta blocker plus aldosterone blocker. So there are many reasons, and also we are the dosage which they receive, these patients receive are significantly lower. They are not being titrated to the highest possible levels or the maximum tolerated levels. That also contributes to the long-term outcomes. So all these factors contribute, and the compliance issues, cost issues, because heart failure will require lifelong therapy, and all this contributes to the higher mortality in the Indians, which actually starts from the in-hospital mortality itself. It is around 4 to 6% in the Western settings. It is 8% consistently from 2013 to 2018 in the Indian settings.
Also, in the sub-analysis of your data, Dr. Hari, you demonstrated that those who received guideline-directed medical therapy, their prognosis was much better and mortality much lower. Also, we had a registry of about 5,800 patients of reduced ejection fraction. And it was a single-center hospital-based registry where obviously people got a much better guideline-directed medical therapy, and there the mortality was nearly half of what was shown in other registries.
So now coming to the third component, which was the diagnostic component, I think it is important for all the groups to understand how to diagnose a heart failure. So it is the clinical syndrome of both left heart pulmonary venous congestion and systemic venous congestion. Added to today you need to have an ejection fraction to basically really understand the structural component of and the functional component of what the cardiac problem is, and added with BNP. So please understand that BNP gives you an absolute idea to heart failure. BNP is like serum creatinine of nephrology. In every patient who is suspected of heart failure, you need to have a BNP. If you do BNP in all the patients as the West does, and once the cost comes down, then you will have a much larger incidence of heart failure, which probably, of course, by the time even heart failure with preserved ejection fraction also you will pick up, because you have a normal ejection fraction and the BNP has gone up. It's very likely that you will classify into heart failure with preserved ejection fraction. But remember, in the diagnostic conundrum, BNP is a very important aspect, which still I would assume is underused in the entire practice of heart failure. Professor Chopra, on that component of BNPs.
Yeah, so the assessment of natriuretic peptides, of course, is very important. And it is, at the lower end, there are a few uses. At the lower end, it is a negative predictive value. It is more to rule out rather than to rule in. You can have relatively low BNPs even in presence of heart failure. Heart failure with preserved ejection fraction will generally have lower BNP. And there are several other conditions like old age and presence of renal failure and atrial fibrillation, which impact the levels of natriuretic peptides. Also, in today's times, when we are using more and more ARNI, it is important to measure NT-proBNP rather than BNP, because BNP levels will be high in patients on ARNI. That is how the medicine works. I think maybe we can go on to the next talk.
Next topic, yes. Actually, we are on time. We are on right on 9:30.
Okay. Okay.
So question from the audience. Whether mild global hypokinesia of left ventricle considered as heart failure?
Yeah, sure. It is considered as heart failure. Any reduction in ejection fraction is considered as heart failure. So we have to basically we have to initiate the guideline directed therapy in these patients. We will come to that. We will come to that when we discuss. Global hypokinesia, if the ejection fraction is lower than normal, I think we should start on the 4 pillars of heart failure therapy.
Thank you, sir. Now we move on to the first session, next session. Now I invite Dr. Bhagavati Prasad Pant, postdoctoral fellow, SCT IMST, to present scientific topic on heart failure definition and classification.
Hello, good morning. Thank you, Shri Chitra Institute and Heart Failure Association of India to give me this opportunity to speak on heart failure today. Respected teachers and chairpersons, I'll be discussing about heart failure definition and classification. So as we know, this heart failure is a global pandemic. Almost every country is affected by this. And various heart failure associations have come with their definitions all around the world. The American Heart Association it defines heart failure as a complex clinical syndrome from any structural or impairment of ventricular decreased ejection of blood. However, in the European Society, it defines heart failure as a clinical syndrome which characterized by typical symptoms and signs and caused by structural or functional cardiac abnormality, which result in reduced cardiac output or elevated intracardiac pressures at rest or during stress. The Japanese Cardiology Society defines it is a clinical syndrome with symptoms of heart failure like dyspnea, malaise, and decreased exercise capacity due to the loss of compensation for cardiac pumping function. So although these definitions were accurate, but they were quite impractical for to put in epidemiological side or in practical purpose. They had something in common, like they defined heart failure, it is a clinical syndrome. They require presence of at least some of the cardinal symptoms, and it requires some form of structural or functional heart disease. But these definitions were quite impractical for the clinical studies and epidemiological studies. So heart failure associations, they joined hand, and in 2021 they came up with a universal definition and classification of heart failure. So this was endorsed by Heart Failure Association of India also, and the major stakeholders in these universal definition of heart failure was not only physicians and nurses. They included pharmacists, clinical trialists, industrial regulators, and even patients also. So the key points of these documents were they defined heart failure. They gave a universal definition of heart failure. They revised the stages of heart failure, which were initially given by American Cardiology associations, and they revised classification according to the left ventricular ejection fractions. So coming to the universal definition of heart failure, they defined it as a symptoms and signs of heart failure caused by structural or functional cardiac abnormality. And this was determined by any EF of less than 50% or abnormal heart chamber enlargements, or E by E dash, which is the echocardiographic parameter of more than 15, any abnormal ventricular hypertrophy, or any valvular obstructive or regurgitant lesions. With the symptoms and signs, they also they added by at least one of the two things. The initial thing was the initial elevated natriuretic peptide levels by raised BNP and anti-proBNP levels, and or objective evidence of cardiogenic pulmonary or systemic congestion, which was determined by diagnostic modalities like chest X-ray or echocardiography, or by hemodynamic measurements by right head catheterization or pulmonary artery catheter, or choosing the elevated filling pressure by at rest or by provocation. So they define the symptoms of heart failure as a typical and less typical. The major typical symptoms with dyspnea, it was orthopnea, paroxysmal nocturnal dyspnea, reduced exercise tolerance, and bendopnea, ankle swelling. They were the major typical symptoms which they defined. Less typical symptoms like nocturnal cough, wheezing, loss of appetite, confusion in elderly, depression, dizziness, and syncope were less typical symptoms. The signs of heart failure, the more specific symptoms like raised jugular venous pressure, a third heart sound, cardiomegaly, or hepatojugular reflex, and advanced heart failure, the kinase stroke respiration were more specific sign of heart failure, and less specific signs like peripheral edema, pulmonary rales, weight loss, tachycardia, tachypnea, oliguria, narrow pulse pressure, they defined as a less specific. There is a different lecture, separate lecture for all this, and it will be discussed later. The major inclusion with this universal definition of heart failure was the natriuretic peptide levels. They were notably absent from previous heart failure definitions, and with this universal definition of heart failure, they were made as an integral component of heart failure diagnosis. And especially when the diagnosis is uncertain, the BNP levels, they help in the heart failure diagnosis. The BNP level in an ambulatory OPD patient more than 35 picogram per ml, and in a hospitalized or a decompensated patient more than 100 picogram per ml, it defines heart failure. Similarly, the anti-proBNP level of more than 125 and more than 300 were given as cutoffs for diagnosis of heart failure in this document. So coming to the classification of heart failure, the major classifications which we use like NYHA, ejection fraction, etiology, like the classification of etiology and disease progression, Modi's classification, and for advanced heart failure, I'll be discussing in one by one. So NYHA classification is the major classification which we use daily in our clinical setup. This grades patients who have cardiac disease into 4 categories. The class 1, they have no limitation of any activity, and they can perform ordinary activities without any limitations. Class 2, they have mild symptoms, and they have mild limitation of activities. They have no symptoms at rest. Class 3, they are comfortable at rest, but they have marked limitation of their activities. And class 4, they are very symptomatic at rest, and they cannot do any physical activity without any discomfort. So this was the major classification which was used in heart failure registries and heart failure trials also. It has a major inter-observer variability. For universal definition of heart failure document, they defined the stages of heart failure into 4 categories. Although it was defined by ACC before into 4 stages: stage A, stage B, stage C, and stage D. Telling a patient who is at only the risk of heart failure is not in heart failure, telling you are in stage A heart failure was generating a stigma in the patient. So in the universal definition, they have changed it to the at risk for heart failure. Stage B, they have changed it to pre-heart failure, and stage C, the patients who have a heart failure, and stage D is advanced heart failure. So patients who are at risk of heart failure, they don't have any symptoms or signs of heart failure, and they don't have any structural disease of heart. These patients are the patients who have hypertension, coronary vascular disease, diabetes mellitus, and obesity, or some exposure to cardiotoxin. The pre-heart failure stage, these patients also, they don't have any symptoms of signs of heart failure, but they have evidence of at least structural heart disease or abnormal cardiac function or elevated natriuretic peptide levels. The stage C group, which is the heart failure group, these are the patients which we see in our OPD or in ICU admissions, where the patients with who have the current or prior symptoms and signs of heart failure, and they have structural and functional cardiac abnormality. And they are further divided into persistent heart failure, is that patient who is continuously in heart failure, he is not improving or not deteriorating with the therapies, and those patients who has recovered. So heart failure in remission term was given instead of recovered heart failure. In advanced heart failure, These patients have severe symptoms of heart failure at rest, and they are hospitalized and they require advanced therapies. But these patients with the guideline-directed medical therapy and risk factor modification, they can be their trajectory can be changed to stage C or even stage B. So those patients who are at risk of heart failure, they can come in stage A heart failure. The major treatment about these patients is the optimal control of their risk factors, like patient with hypertension, optimal control of BP, optimal control of cardiovascular disease, and multidisciplinary evolution management for cardiotoxic, those patients who have exposed to cardiotoxic agents, and genetic screening were included. Similarly, for pre-heart failure patients who have ejection fraction of less than 40 or more than 40, the class 1 indication for all the 4 pillars of heart failure is a class 1 indications. And these pre-heart failure patients also, they should continue lifestyle modification and management strategy which were implemented for them in stage A. The pathway for the stage C heart failure patients, these patients which we see in OPD or in ICU, they are newly diagnosed heart failure or no previous history of heart failure. They are known as new onset or de novo heart failure. Some patients after treatment, they have resolution of symptoms and signs of heart failure. Some patients will be in persistent heart failure who have ongoing symptoms and signs and limited functional capacity, and worsening heart failure who have worsening symptoms and they are going to stage D or advanced heart failure stage. So this is the pathway where stage C patients or a heart failure patient comes to admission with decompensation or in acute heart failure. In the early stage, the guideline-directed medical therapy is started and trajectory is evaluated at proper intervals. And we have to check whether this patient is improving towards the target and it is or whether it is not improving and going into advanced heart failure. And during the admission only, the transition to oral therapy should starts. And just before discharge, the maximum medical therapy or optimization should be maximum for this patients. And they should call before early post-discharge phase, and they should be given transition to chronic care accordingly. Coming to the classification of heart failure by left ventricular ejection fraction, in universal definition, they defined heart failure with reduced ejection fraction as when the EF is less than 40%, mildly reduced EF when there is EF of between 41 to 49%. Reserved ejection fraction was defined when the ejection fraction was more than 50%, and improved ejection fraction was defined when the baseline ejection fraction was less than 40% or more than 10-point increase from baseline LVF when there is second measurement in the future. So based on based on the EF, the trajectory of the patient in the serial assessment, all the three categories of heart failure, they can change to other categories like less than 40%. If their EF improves, they can be into heart failure with improved ejection fraction. Earlier, it was defined as heart failure with recovered ejection fraction. Recovered ejection fraction definition, it gives a false sense of security that a patient has recovered, but it is not recovered. It is improved ejection fraction where the structural abnormality is still present, but patient symptoms are less. Coming to the heart failure with ejection fraction, this contributes almost half of the heart failure patients. As you see in the normal heart, which have normal filling pressure, the heart failure with preserved ejection fraction has a diastolic dysfunction, which is defined as impaired relaxation of the heart, and they have less chamber space in the left ventricle, and because of thicker left ventricle and increased filling pressure, this can be explained with the analogy of a balloon on a football, where a normal heart is like a balloon, where we can which have low filling pressure, and we can blow the balloon with our mouth. But a patient with a preserved ejection fraction has a high filling pressure, and it is like a football where we cannot fill the air with our mouth, and we need high pressures like air pump to fill the football. So it is very common in both community and hospital setting, and it is associated with morbidity and mortality approximately equal to that of reduced ejection fraction. Then, although this definition of clinical syndrome heart failure is necessary, but it is important that we subclassify this heart failure and give targeted therapy to individuals. So this Morris classification, which is endorsed by World Heart Federation, it was given in 2014. It defines heart failure into 5 classes. It divides into morphofunctional phenotype. Either it could be dilated, hypertrophic, or restrictive, according to organ system involvement, whether heart and other system like nervous, cutaneous, kidney, or gastrointestinal system is affected, and the genetic inheritance pattern, whether it is sporadic or sporadic or familial pattern is involved. The etiology, whether it is a non-genetic or genetic, whether myocarditis or viral infection, this etiology was given. And stages of heart failure, as we defined the functional status by NYHA and ACC stages, were given to this classification. The last classification, which usually is used in Western literature for the advanced heart failure patients. This advanced heart patients are already in class 3 and class 4, and this Intermax classification is divided into 7 classes, where the most sicker patients are class 1, who are in critical cardiogenic shock and they need urgent mechanical circulatory support or cardiac transplantation within hours. Similarly, stage 2 and stage 3 also need MCS intervention within weeks and days. So to conclude my talk, the definition and classification of heart failure now, as endorsed by Heart Failure Association of India also, the definition includes the symptoms and signs caused by septal or functional cardiac disease, and it should be associated with at least one of the following. Either it could be elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion. The stages, as I told, at risk, pre-heart failure, advanced heart failure stage, and classification is by heart failure with reduced ejection fraction with ejection fraction of less than 40, mildly reduced ejection fraction with 41 to 49%, and preserved ejection fraction with the ejection fraction of more than 50. The new term with the improved ejection fraction, those patients who have ejection fraction of more than less than 40% and they have a 10-point increase from baseline EF with the second measurement of EF of more than 40%. So this definition was given because for a better reach to the society, to the caregivers and to the patients. And its definition offers opportunities for more precise communication and description with terms including persistent HF heart failure instead of stable heart failure, and heart failure in remission rather than recovered heart failure. Thank you.
Thank you. So I think it was a very nice summary of the different classifications. We have to understand that there are different classifications connote different things. When we are talking about stages of heart failure from preclinical till advanced, that tells you what are the conditions which are likely to lead on to heart failure, going through different stages, ending up with severe heart failure. NYHA classification refers to symptoms of heart failure, and left ventricular ejection fraction, despite all its inherent flaws, still has a tremendous use when you're going to follow up these patients. Ejection fraction is not a fixed entity, as was highlighted, because with treatment and even spontaneously, it can change. So it can improve or it can get worse. So it can go from one area to the other within a few days or weeks also. The term mildly reduced ejection fraction has replaced mid-range ejection fraction, because by and large, it has been seen that mildly reduced ejection fraction patients behave much like reduced ejection fraction in terms of their response to different therapies, drugs, and so on and so forth. So basically, they need to be treated as heart failure with reduced ejection fraction. And also, this mildly reduced ejection fraction depends upon where it is coming from. Was it a heart failure with preserved ejection fraction, which is getting better, or whether it was heart failure with reduced ejection? Was it heart failure with preserved ejection fraction, which is now deteriorating, or was it heart failure with reduced ejection fraction, which is getting better? So I think these are various nuances that one should understand, because in the trajectory of heart failure, moving from one class or one stage to the other is very common. Dr. Ajit?
Yeah, so I'll just post a couple of two small problems which.
Dr. Ajit, you're muted probably.
I found this on the web.
Yeah, now it's okay.
Yeah. See, there are a couple of problems that most the residents and the staff ask regarding, the classification. So where do you place these patients who have, features of sarcoma or any of the infiltrative heart disease but normal LV function? Do you class them as heart failure with preserved ejection fraction, or is it anything different? That is one. The second is patients who have LV dysfunction typified by the post-MI patient who have LV dysfunction is not symptomatic but has a raised BNP. So do you also classify them in this heart failure with reduced ejection fraction, or do you just call them as, where do you classify them? Yeah, Professor Chopra, I think.
So I think when we are talking about infiltrative diseases like sarcoidosis, amyloidosis, and they are in heart failure is a clinical diagnosis. So when they are in heart failure, it comes under heart failure with preserved ejection fraction. But also one should be clear that they do not respond to therapies as well as the regular heart failure with preserved ejection fraction. For example, those with ischemia or with hypertension and so on and so forth, because there's a structural disarray of the myocardium in these patients. Even in the Emperor Preserve trial, if you took the very elderly people and there was a class which did not respond well, it was guessed that many of them had probably amyloidosis, which is something which is very common. So yes, it comes under heart failure with preserved ejection fraction, but with a clear understanding that they are not likely to respond to pharmacotherapy in the same way that heart failure with preserved ejection of other or the common garden etiologies. The next point is when your natriuretic peptides are high. So I think this will go under left ventricular dysfunction. If they have no symptoms at all, then heart failure, as was mentioned in universal definition, it's a clinical diagnosis. So it will go under heart failure, left ventricular dysfunction, and with the potential to go into the clinical heart failure. And it might well come under stage 1 or stage 2 of heart failure, depending upon the rest of the parameters.
I think we are running short of time. I think I would request all the speakers to keep a time limit of 12 minutes so that we can have some more discussion. Is there one more question from the audience? Can send a question to the chat box. What are the most effective methods to detect a heart problem? Let's call it heart failure. So what is the most effective investigation to detect heart failure? Bhagwati?
Investigation wise, it should be echocardiography initially, or blood levels of natriuretic peptides. Otherwise, it should be associated with the signs and symptoms of the disease. Then collaboratively only we have to diagnose it as a heart failure. There is no single investigation which can define heart failure, but it should be associated with signs and symptoms of the patients.
So clinical signs and symptoms associated with the corroborative evidence of heart failure as evidenced by a structural abnormality on an echocardiography and or brain natriuretic peptides. This is the universal definition.
Yeah. Yes. See, in fact, this question comes when in the general OPD, so you don't have a cardiologist sitting down, or you do not have an echo facility. So how do you classify this patient into heart failure or into something else? I think, as you mentioned, apart from the clinical examination, a BNP will help you triage the patient towards a heart failure component or otherwise, after which the echo and other factors will help it. I think we will go on to the next topic. What is the pathogenesis of heart failure? Professor Chopra, you made a note that you wanted to.
You are muted, sir. Sir, you are muted.
Yeah, sorry, I have to leave. But anyway, thank you very much. Wonderful discussion, and all the very best for the rest of the meeting.
Thank you, Dr. Chopra, for that. We really appreciate you. Yes.
Thank you.
Rohit, pathophysiology of heart failure.
Good morning, everyone. First of all, I would like to thank the organizers for providing me the opportunity to present at this prestigious conference. I'll be speaking on pathophysiology of heart failure. So as we all know, the heart failure is a clinical syndrome, and it's defined by structural and functional cardiac abnormality corroborated by elevated natriuretic peptide levels. So how this structural or functional deterioration occurs in heart? So it starts way back, some years back, when the patient is asymptomatic, when the ejection fraction is normal, and over a period of time, there is this structural and functional deterioration leading to symptomatic patient with reduced ejection fraction and development of heart failure. So the natural history of heart failure dates back in a very early stages of life, when there are some environmental determinants, genetic determinants, and lack of physical activity leading to some structural changes in the vessels as well as in the myocardium, and then leading to dysfunction of the heart and leading to development of symptoms or gross heart failure. So to understand this, first of all, we look at what is ejection fraction, the amount of blood, the fraction of blood that is ejected out of the heart per beat is the ejection fraction, which is modified by whatever the preload comes into the heart and what is the resistance at the as an outlet of heart. So there will be some blood coming into the heart, which is preload. There's a volume of blood, and afterload is the resistance to the heart to pump this blood. So normally what happens is it is not that 100 ml blood will come into the heart and 100 ml will be ejected. It will be lesser because there will be some inherent resistance, and normally this amounts to 50 to 60%. That is what we call as ejection fraction. This is again affected by the preload will be the volume, and it depends on the venous return, whatever blood that comes from all the organs to the heart, and also how is the compliance of the heart, whether it is stiff or it is compliant enough to accommodate whatever blood comes to it. And afterload is determined by the systemic resistance and the pulmonary arterial resistance. So it is the force that is needed to eject the blood into the circulation. So as we all saw that heart failure was classified into main 4 categories. I'll be mainly focusing on heart failure with reduced ejection fraction, where the ejection fraction is less than 40%, and heart failure with preserved ejection fraction, where the ejection fraction is preserved, but patient still has heart failure. So this heart failure with reduced ejection fraction is also known as systolic heart failure, which occurs mainly due to coronary artery disease, as we discussed previously. And the second one, heart failure with the diastolic preserved ejection fraction, which is also called as the diastolic heart failure, where the ejection fraction more or less remains more than 50%, but still the patient will have heart failure because the ventricle is unable to relax and fill completely or as required during the diastole. So to understand pathophysiology of heart failure, there is an indexed event, which is the injury to the heart, which is followed by a lot of compensatory mechanisms. And those mechanisms initially help to maintain the cardiac output, but progressively over a period of time worsen the structural integrity of heart and lead to progressive heart failure. So I'll be mainly focusing on main 3 components of this pathophysiology. First one is the sympathetic nervous system, second is the renin-angiotensin system, and third is the natriuretic peptide system. So what happens whenever there is an injury to the heart, like let's say there's a myocardial infarction. So initially what will happen is that heart is not able to pump to the required demands of the body, and there will be activation of certain compensatory mechanisms. So first compensatory mechanism will be the increase in sympathetic activity, where there is a stimulation of the beta receptors, which leads to increase in the heart rate and force of contraction, leading to increase in cardiac output, and stimulation of alpha receptors, which lead to vasoconstriction. So this stimulation of sympathetic activity for a short term helps in maintaining the cardiac output, but gradually it increases the myocardial demand, and also with the withdrawal of parasympathetic activity leads to reduction in the nitrous oxide and progressive inflammation, which in turn activates the sympathetic system and leads to progressive worsening of heart function on a long term. So this is how sympathetic system behaves during heart failure. The second mechanism is renin-angiotensin system. Because of reduction in cardiac output, there will be renal hypoperfusion. So there is less sodium delivery at the macula densa, which stimulates renin secretion. And also sympathetic stimulation of the juxtaglomerular apparatus secretes renin. This renin activates angiotensinogen to angiotensin 1. And with the help of lung ACE enzyme, it gets converted into angiotensin 2. So this angiotensin 2 acts on angiotensin 1 receptor and angiotensin 2 receptors. These lead to vasoconstriction, sodium water resorption, cell proliferation, increase in aldosterone secretion, which also in turn helps to maintain the cardiac output in the initial phase. But with increase in activation of this mechanism, where the AT2 receptors are also get stimulated, there is stimulation of the fibroblast cell, which leads to development of fibrosis and progressive worsening of heart function over a period of time, leading to heart failure. So whenever this is a normal heart, this is a animative depiction of the same. During activation of the sympathetic system, there will be hypertrophy of ventricle, which in initial period will help to maintain cardiac output, but gradually will develop diastolic heart failure first with development of fibrosis. And as it progresses, the patient will later on develop dilated cardiomyopathy and gross heart failure. So this is the routine course of compensatory mechanisms help initially in maintaining the cardiac output. But when they go on producing the inadvertent changes like fibrosis, there is a counter-regulatory protective system in the heart, which is a natriuretic peptide system. So what happens is the ventricular myocardium, due to stretching of the heart, secretes brain natriuretic peptide, which gets converted into NT-proBNP, which has many favorable effects like vasodilatation, natriuresis, whichever sodium causing harm to the heart.
Bhagavati, you are not audible. Bhagavati, you are not audible.
Hello, am I audible?
Yeah.
Your audio is lost. Yeah, now you are audible. Yeah, please go ahead.
Yeah. So I was talking about this protective counter-regulatory mechanism where brain natriuretic peptide is secreted due to stretching of the heart, which gets converted into NT-proBNP. And this initially helps in vasodilatation and loss of sodium and water and inhibits fibrosis. But the only disadvantage is that this is a short-term system. So due to neprilysin or the neutral endopeptidase enzyme, this system is inhibited very early. And because of that, the progressive changes which were happening initially continue to happen, and they lead to development of heart failure. So this progressive long-term neurohormonal response leads to development of systemic inflammatory activity, leading to cardiac wasting, muscle myopathy, and fatigue. So these structural changes in the shape, size, structure of the heart are progressively known as cardiac remodeling. So this cardiac remodeling in turn leads to development of heart failure and will result in development of decompensated heart failure or the pulmonary edema. To summarize, pathophysiology is when there is sustained myocardial injury leading to reduced cardiac output, which initially activates sympathetic nervous system, leading to increase in heart rate, and reduction in renal blood flow leads to activation of the renin-angiotensin-aldosterone system. Both of them leading to arteriovenous vasoconstriction, salt water retention, ventricular hypertrophy, which initially helps to maintain cardiac output, but progressively lead to development of remodeling of heart, which is counterbalanced for a short term with natriuretic peptide system, and finally lead to development of heart failure. Thank you.
Yeah, thank you, Rohit, for clarifying the pathophysiological aspects of heart failure. So coming to some specific aspects, because we don't have much time on this, but let us concentrate on some specific aspects. Now, in terms of the role of sympathetic nervous system, why do you think, or why should we add drugs that are counter to the sympathetic nervous system? How will it basically help in the management from a pathogenetic point of view?
As we discussed initially, this prolonged activation of sympathetic system is bad. The initially it helps to maintain cardiac output, and the short-term mechanism actually is beneficial during the initial course of compensatory activity. But by using drugs to counteract this sympathetic system, we are actually reducing this prolonged activation, which is in later phase is detrimental. So to prevent that detrimental effect and remodeling of heart in the later phase, we are actually using anti-sympathetic drugs in the management of heart failure.
Yeah, Dr. Hari, any?
Yeah, the chronic sympathetic activity, the chronic high sympathetic activity is detrimental to the heart. So to prevent that, we are giving beta blockers. So that is the important thing. I think that is understanding which came later, because when we were medical students, we were told that beta blocker, because sympathetic activity maintains the cardiac output, so giving beta blocker was contraindicated at that time. Then came the major studies which showed that beta blocker on the long-term sympathetic activity is detrimental and beta blocker benefits. That is how it came as the first-line therapy in heart failure. So similarly, the ACE inhibitor. Yes, sir. Sir,
yeah,
please go ahead.
go ahead. Yeah.
Similarly, the ACE inhibitor, the RAS system activation also, it has to be, these are all regulatory mechanisms which on the long term is counterproductive. That is why we are giving drugs which will interact with that. And now the newer class of drugs like SGLT2 inhibitors, which is actually came as an anti-diabetic drug, which has multiple effects on all these systems. It is a diuretic effect, it has an effect on the myocardium, it has effect on the renal aspects. So all these aspects will help in improving the long-term outcome of heart failure.
So thank you. I think we will go on to the next.
Can I add one point if there is time?
Yes, sir, please.
Apart from the beta blockers, if the patient is already on beta blockers and still has not improved, ivabradine is also shown to have some mortality benefit.
Yeah, by reducing the heart rate, ivabradine has been found. If the beta blocker is not on the maximum doses, beta blocker is not able to reduce the heart rate to below 70, then we have to add ivabradine, which will improve the outcomes in heart failure.
See, it is very interesting to note that the heart rate is a peculiar thing in this entire spectrum of animals and mammals. Somehow, as the animal's life grows, or if the heart rate of human being is 72, the whales have a heart rate of only about 50, while small animals that live shorter is basically a rat would have a heart rate of around 200 beats per minute. So the number of heart rate into the number of years lived is a constant in the universe. So overall, what it basically implies is that the metabolic aspect of the heart is somewhat of a relatively fixed component. And if you can bring down the heart rate to the metabolic needs within the range of acceptability, hemodynamic acceptability, then it is good. That's probably the reason why your, ivabradine and beta blockers improve the cardiac function when you bring down the heart rate to acceptable limits. So I think, shall we go on to the next topic, after which Dr. Hari will present some important slides on the treatment aspects on science and heart failure by, just a minute. Yeah, by Bindu Michael, Senior Nursing Officer in HFIC. Yes. I think you're not audible. Can you click on the?
You are not audible.
You have to come a little closer to the.
No, still you are not audible. Yeah, you can put it on again.
Okay. Try.
Yeah, you can go on speaking. I think there is some issue with the audio.
of heart failure.
Yeah, go ahead. We can hear you now. Some delay is there. Yeah. Please go ahead. There is some delay. Please go ahead.
No, it's okay. You can go ahead. You can start.
The heart is unable to pump enough amount of blood to meet the metabolic demands of the body. Initially, heart tries to compensate with the sympathetic nervous system activation by increasing the heart rate, and there will be vasoconstriction, and thereby cardiac output is increased. Then neurohormonal responses, that is renin, angiotensin, aldosterone mechanism activates, fluid and water retention, preload is increased, cardiac output is increased. Then there is ventricular hypertrophy and ventricular dilatation. It is important to recognize signs and symptoms to diagnose, prognosticate, and follow up. The signs and symptoms of heart failure is either due to systemic or pulmonary congestion, or it is due to reduction in cardiac output. We'll see the symptoms related to systemic or pulmonary congestion. There is shortness of breath on exertion. Orthopnea, the patient will have difficulty in breathing in lying down position, and paroxysmal nocturnal dyspnea, that is a sensation of shortness of breath that awakens the patient 1 to 2 hours of sleep. He will sit in upright position, and after some time he'll get relief and will go back to sleep. It is due to fluid redistribution, and in recumbency position, the LV is failed, and there will be increased load in the left ventricle. That LV is not able to eject like RV, which is ejecting normally. That leads to paroxysmal nocturnal dyspnea. Then patient will be presenting with dependent edema in the feet, sacral region, and the scrotal area. Whichever may be the dependent area, there all edema occurs. Cough, especially nocturnal cough, that is also due to fluid redistribution. Pulmonary venous congestion, fluid leaks into the lungs. The body tries to expel it out by persistent cough. In pulmonary edema, patient will be presenting with blood-tinged frothy secretions. Pain in right upper half of the abdomen, that is due to hepatomegaly, that is congested liver. Then abdominal discomfort is due to ascites, or hepatomegaly also can contribute to the discomfort. Then most often the patient will be presenting with the bendopnea, that is dyspnea on bending forward and exerting. Signs related with systemic or pulmonary congestion are increased respiratory rate, pulmonary raise or crepitation on auscultation, that is due to air passes through the fluid. Elevated jugular venous pressure, that normal jugular venous pressure is 6 to 8. If it is more than 8, that is called elevated jugular venous pressure. Pedal or sacral region edema, scrotal edema, hepatomegaly, ascites, unilateral or bilateral diminished breath sound, that is seen in pleural effusion. Symptoms related with the reduction in cardiac output are fatigue and weakness. The dyspnea, fatigue, and edema are the cardinal signs of heart failure. This fatigue and weakness is due to decreased cardiac output. There will be tachycardia, so a patient will present with palpitation. Decreased urine output is that is resulting from the decreased renal perfusion. Diminished exercise capacity, that is less amount of cardiac output is reaching to the extremities, tissues, and bones. Because in cardiac failure, what happens is more amount of blood is directed towards the vital organs. So the patient will have decreased exercise capacity, easy fatigability, all those things in various amounts we can see in patient with heart failure. Behavioral changes is resulting from cerebral decreased cerebral perfusion. Patient will be presenting with restlessness, confusion, decreased attention span, or memory loss. Most often the somnolence, that is patient, even during the daytime, the patient will be sleeping. That is also due to decreased energy resulting from the decreased cardiac output, activity intolerance, all those things leads to this somnolence, that is sleepiness always. Signs related with the reduction in cardiac output are hypotension, decreased BP, pulses alternance, that is due to left ventricle congestion. There will be resistance in LV ejection. There will be alternate strong and weak pulse. Tachycardia and narrow pulse pressure. All of you might be knowing what is narrow pulse pressure. In pulse pressure is the difference between systolic and diastolic pressure. If it is normal, is 40 to 60. If it is less than 40, that is called narrow pulse pressure. Lethargy, that is generalized tiredness, will be there. Decreased peripheral perfusion leads to skin changes like dusky skin and hair loss will be there. Cool extremities, pallor, and poor capillary refill also resulting from decreased peripheral perfusion. Capillary refill we can check by pressing the fingertip. There will be blanching. If after releasing, if the normal color is returning within 3 seconds, it is normal capillary refill. If it is getting delayed, that is called poor capillary refill. Signs and symptoms in heart failure are weight gain due to excessive accumulation of fluid, weight loss, that is in cardiac cachexia, that is seen in patients with the chronic heart failure, unintentional weight loss, that is resulting from loss of fat, tissue, and bones density, that in chronic heart failure that is seen. Early satiety, that is even after eating a little bit of food, patient will be feel fullness, or patient will be satisfied. That may not be enough to meet the nutritional needs of the patient. That also lead to cardiac cachexia in chronic patients. This early satiety can be resulting from post-splanchnic circulation and gut wall edema. Nocturia is also often seen in patients with heart failure. That is due to fluid redistribution in recumbency. More fluid will return to the heart. What happens is that there will be sodium excretion, improved hemodynamics that leads to improved urine output at night time. There will be palpable or audible S3, cardiomegaly, laterally displaced apical impulse, even can be palpated on the chest wall. That will be in the mid-clavicular line, fifth intercostal space. We can palpate that. Ectopic beats or irregular rhythm, atrial fibrillation is most common in heart failure. Murmurs also, that is tricuspid or mitral regurgitation murmur, is common in heart failure. If it is associated with rheumatic heart disease, other murmurs also heard. Patient will have chain stroke breathing. It is a specific form of periodic breathing characterized by alternating apnea and hyperventilation. These are the signs and symptoms of heart failure. To conclude, assessment of signs and symptoms helps in diagnosis. Signs and symptoms are the indicator of deterioration of the pathophysiological process. It helps to alter or consider new forms of therapy. Signs and symptoms are utilized for assessing fitness for discharge. Thank you.
Thank you. Thank you for that excellent and lucid talk on the signs and symptoms. I think it is quite clear what all signs and symptoms that you need to look at, both for diagnosis as well as for assessment of heart failure. Coming to the assessment, I think one of the most important part of a diagnostic of assessment of signs and symptoms is the symptoms. If a patient has symptoms of dyspnea and has signs of edema, which are two very simple things that you can ask, then it is quite likely that the patient has features of cardiac failure for which you need further investigation. For the resident, he has to look for features of systemic venous congestion via raised jugular venous pressure. So a combination of cardiomegaly, features of LV dysfunction in the form of S3, features of pulmonary rails on the left side, and features of raised jugular venous pressure and edema in the limbs is an indicator of cardiac failure. Now with this, you go on to the next phase. Do we have any questions coming up? And in children, I wanted to make a mark. Dr. Krishnamurthy, would you?
Yes, sir.
Yeah. I mean, are there any specific features of heart failure in children which is different from that of adults?
Yeah, children, the most important, a few differences is, one is the very low, of course, because of etiology, the congenital heart disease scores very high in the list, one thing. And coronary artery disease naturally comes down. That is one. The other thing is that all the trials and all the medications are directed towards the left ventricular function. Whereas in majority of the congenital heart disease, it is the systemic right ventricular function that is important, which does not behave as equally or as similar to left ventricular function. That is another. And all these trials have, most of them are the medication, the current guidelines are superimposed or extrapolated to children. There are no large scale trials in children. The other thing is that this NYHA classification is not applicable to especially the younger children. In younger children, the Rose classification is used, whereas where we take into account the sweating and the feeding difficulty, which is not there in class 1, Rose class 1, mild, or moderate, or severe, like the 4 classes of Rose. NYHA is not useful in children. These are the differences I would like to highlight. And also for classification, a very simpler classification instead of the reduced ejection fraction, all those things in children, it is the heart failure due to pump failure or heart failure due to circulatory failure. Circulatory failure where we have shunt lesions producing heart failure, whereas in pump failure, we have all the myocardial disease or valvular disease which produce heart failure. These are the essential differences.
Yeah, to just make a short summary or something which is different in children, apart from the etiological aspects of cardiac failure, the symptoms that you should look for is poor feeding difficulty, in the child having tachypnea and becoming restless on feeding. So these are the 3 more important features. In addition to the cardiac findings, you will find there is significant amount of sweating, or you find what is known as head sweats. These are all indications of increased sympathetic activity. So these are some of the symptoms and signs in addition to what Dr. Krishnamurthy has said. I think before we go on to the next session,
One more is that the intercostal withdrawing is a very important feature, especially in infants, which the nurses can easily recognize, and it is considered to be class 4.
Yes, on the bed. In fact, one of the most important feature which anybody should recognize is the tachypnea. The child in cardiac failure is tachypnic. So which the mother recognizes, the nurse recognizes, the doctor recognizes, in addition to all other symptoms that we have discussed. Dr. Hari Krishnan will now present some important aspects on the therapy of heart failure. What is the guideline directed treatment? And then we'll go on to the next session.
Can you see my slides, sir?
Yes.
So actually, we didn't have any presentation on the guideline directed therapy. So I thought I will show 4 slides on the guideline directed therapy, the latest guideline directed medical therapy in heart failure. So this is the current standard core medical therapy according to the 2021 guidelines for heart failure with reduced ejection fraction. So we have the 4 pillars of therapy, 4 pillars. That is the beta. The first is the beta. The first is when the patient presents with congestion, we have to decongest by giving diuretics. But diuretics doesn't have any mortality benefit. It has only symptomatic benefit. But the mortality benefit is by the 4 pillars: beta blockers, ACE inhibitor or ARB or ARNI. And the third is a mineralocorticoid receptor antagonist, and the new class of drugs which is added as a 4th pillar, that is the SGLT2 inhibitors like empagliflozin and dapagliflozin. So these are the 4 pillars of therapy in heart failure with reduced ejection fraction. In addition to this, we have the devices like ICD or the defibrillator and the CRT, which is the cardiac resynchronization therapy to improve the outcomes of patients with heart failure. So there are other therapies also. For example, when the patient cannot tolerate an ACE inhibitor or due to renal dysfunction, we can give a combination of hydralazine nitrate. When the heart rate is more than 70, despite beta blocker, we can give ivabradine. There are two new drugs which are coming up. One is vericiguat, which is going to be introduced in India in few months, and omecamtiv mecarbil, which is found to be effective in heart failure. Then we have other comorbidities which we have to consider. We have to control the blood pressure to less than 130. IV iron in patients who have iron deficiency, because iron deficiency is found to impact the outcomes of heart failure. So IV iron supplementation has been found to be effective. Then management of valvular heart disease, management of atrial fibrillation is important, and management of sleep disorders can be there in heart failure. Then vaccination of influenza and pneumococcal vaccination have been found to be helpful, and management of behavioral aspects like depression also has been found to be effective in improving the outcome of heart failure patients. Another question is when to start these therapies whenever the patient comes. So once a patient comes and the congestion is relieved, we can start on ACE inhibitor or ARNI. Now the ARNI is preferred to be started as the first drug. Then on the patient is achieving or approaching euvolemia, you can start on beta blocker. Then mineralocorticoid receptor antagonists like spironolactone should be started, and the SGLT2 inhibitors like dapagliflozin or empagliflozin can be started before discharge, or in some situations you can start at the beginning itself. Then you have to continue to once the patient is discharged, you have to ensure regular follow-up after first week of the discharge, and adjust the drugs and continue to up-titrate the drugs to the maximum tolerated levels. The beta blockers should go up to 200 milligram in the case of metoprolol, like that. So you have to go to the maximum tolerated levels. So that is how the therapy should be started. So start at the lower doses, titrate to the maximum possible to the guideline directed levels, but in many patients it may not be possible, but you should go to the maximum tolerated levels. Then the other question is when you can stop the therapy. Once the patient has improved significantly, when you can stop that therapy. There are trials which showed that those patients who have improved with a significantly reduced ejection fraction, they once you stop the therapy like beta blocker or these RAS inhibitors, 50% of them come back with symptoms. So we have to continue these drugs indefinitely, even if the patient has recovered. That is one point which I wanted to highlight. This is what is called an improved ejection fraction heart failure. Then what about heart failure with preserved ejection fraction? Preserved ejection fraction, we never had any drugs which was found to improve the outcomes. These are patients with ejection fraction of more than 50%. We have to give diuretics for symptomatic benefit. But recently we have the data on empagliflozin and dapagliflozin, which showed benefit in patients with heart failure with reduced ejection fraction. Those patients, angiotensin receptor blockers, mineralocorticoid receptor antagonists, and ARNI have been shown to be having some benefit, but the most significant benefit was shown in patients with SGLT2 therapy. So that is what I wanted to highlight, because there was no presentation on guideline directed therapy in the session. So thank you. Over to you, sir.
Yeah, thank you all for this session. I'll just make some conclusive remarks. So in terms of prevalence and epidemiology, one of the most important aspects that we have understood is that there is a high mortality, a 1-year mortality of 30% and a 50% mortality in 5 years, which is something which we need to bring down. I, of course, don't believe that there is an epidemic in heart failure. It is basically recognition of the heart failure that we have not done in so many years. So it is important to understand the prevalence and thereby take quick action. On the diagnostic front, everybody should understand that heart failure is a clinical syndrome of pulmonary symptoms and systemic symptoms, along with the simple estimation of BNP. Now, whoever it is, even in the outpatient or otherwise, please understand and remember. Actually, I have been after this for the last 5 years saying that any patient who comes, who can afford and who has a suspicion of heart failure will and should require a BNP, because you might be wrong in your estimations. But if you have to pick up a patient with heart failure with preserved ejection fraction, or in a patient who has mildly reduced ejection fraction, BNP will certainly help you in terms of giving a quick diagnosis. Dr. Harikrishnan has clarified the guideline-directed treatment. And with that, I think I should conclude this session. Thank you all.
Thank you, sir.
Questions are there from audience.
Sorry?
3 questions are there from audience.
Yes. Yeah, okay, yeah. Yes, I think I'll take it first, the second question first. Pneumococcal and influenza vaccination. What is the role in heart failure? I think that's a very important question, and which I certainly agree that even we don't practice it regularly. Can Dr. Hari clarify that this should be done from the ward, that a patient should either be advised or we should actually deliver it? Now, can Dr. Hari clarify on that?
Yeah, I think we should. I think Dr. Sandeep, have you joined? Sandeep, Dr. Sandeep, are you there?
Yeah, I'm just.
Yeah, Sandeep.
Just give me a second to unmute everything.
Yeah, please. So I think Sandeep is the best person to answer because he is practicing it in this clinic regarding vaccination. Sandeep, you are also
we
part
try
of.
and ensure that all patients at least get the influenza vaccine first, and also the pneumococcal vaccine also, because each of these vaccines costs around 1,000–1,500 each. So when we tell them the vaccination, sometimes they say there's difficulty of affording. So we tell them at least get your influenza shot this time. Next time we'll convince them to get the pneumococcal vaccination. The pneumococcal vaccination has to be given once in 5 years only. So that's not an issue. Once you get one shot in, they're fairly okay. And second thing is when to give the influenza vaccine. Normally, we would think that we should give the vaccines in winter months, that means beginning of winter, September, October. But from some of the data which is coming up is that perhaps we should, the peaks that we are getting in influenza in India seems to be coming around April, May, June. So possibly we should think that we should give our patients vaccination sometime around April, May. So the type of vaccine which comes at that time is the southern vaccine. So possibly that is the vaccine we should be giving our patient. But that is just some data which I'd heard recently. And maybe that's the best thing.
And can you just also clarify on, since COVID is there, and does COVID actually, people who have been COVID vaccinated, which obviously all in this part of the country has, and does it have any cross influence on the influenza vaccination?
No, I mean, some of the, if we read the NIH guidelines, they say that you can give COVID and influenza pneumococcal vaccines simultaneously. But what we generally do is that we'll give one of the vaccines initially. So if they got the COVID vaccine, give them a 2-week gap, and then give them a simultaneous shot of influenza pneumococcal, or vice versa. Generally, we give a 2-week gap between the two vaccines. That's the Indian policy. Give a gap of 2 weeks.
There is some evidence that the COVID has some benefit with influenza. It may be it may not necessarily be. It may be only a cross reaction or a cross immunity between the two. So that's probably something which needs to be looked at. Yes. The next question is
regarding the role. Can I add? It is.
Yeah, please.
There is some evidence that immunocompromised are these patients are one thing. And if there is any infection with this Haemophilus influenza and pneumococci are endemic, and sometimes they are epidemic also. If there is any infection with this, they tilts their balance towards worsening. That is why these are advised.
Yeah.
Another question is on mid-range ejection fraction guideline directed therapy. I think all the therapies which have been effective in reduced ejection fraction, all the 4 drugs have been found to be effective in the mid-range ejection fraction also. So we have to give almost the same therapy for mid-range ejection fraction patients, the same therapy as we give for reduced ejection fraction.
The other question regarding pulsation in the neck, the pulsation in the neck may be to a certain extent normal, but most of the time the pulsation in the neck is a reflection of prominent jugular venous pressure, and it is likely that it is elevated. So if the jugular venous pressure is elevated, which somebody can make out, then it certainly is increased. But the moment you find very prominent pulsation, I think you should ask somebody to find out if the JVP is actually increased. So prominent jugular venous pressure is likely to be an indicator of heart failure if the patient has reasons for that. And the last question is,
it could be an arterial pulsations also. You have to differentiate between arterial pulsations, especially in older people, and the venous pulsation. So if it is an arterial pulsation, it may not be, especially in older age, it may not be indicative of heart failure. But venous pulsations, definitely it is indicative of, probably indicative of heart failure. We have to rule out.
And the last is their telemonitoring facility in Kerala. I think Dr. Hari can specifically say on that. There is,
telemonitoring facility. We have the telemedicine network in Kerala. The Kerala government has a telemedicine network, and we have a telephonic follow-up of using the heart failure nurses in our clinic, which we regularly follow patients, and patients call us during office hours, and we give advices to them, and the heart failure nurse consults the doctor in the heart failure clinic and suggest changes in therapy or lifestyle modifications, etc. That is routinely done.
Dr. Sandeep, what is how is it in?
I think Sandeep has a very excellent heart failure clinic, which is a model for the country. I think he will be the best person to answer.
So what we have is that during the peak COVID, we were using an app. So
Sandeep, there is a problem with your audio.
Currently, we are using a helpline number which is connected to WhatsApp. So during office hours, Monday to Friday, the patients are encouraged to make phone calls on that and also leave messages on that. So what happens is that each time the patient phones the first time, his name and numbers enter, and he sends his OPD card also on the WhatsApp. So the WhatsApp itself acts as a sort of store for that patient. So his latest reports, his OPD card, diagnosis, echo reports are all on that WhatsApp. Along with that, we have been using an app called HealthPlix. So on that, it's very simple that you don't have to use your own phones. The phone call goes through the system. So you just have the patient's names entered, give a time for making a phone call. The phone call goes through the app. So that there are two things we've been using. Mainly, we depend on the helpline phone and the WhatsApp. So that works quite effectively because during off hours also, the patient can at least leave a message so that the message can be responded to the next day.
Okay, thank you all. I think we should go on to the next session. I think it's a wonderful discussion.
Yeah, I think who is I think we will go on to the next session. And the next session will be chaired by Dr. Sandeep Seth, the Professor of Cardiology at AIIMS, New Delhi. He is the person running the heart failure clinic, which is a model for the country, and also he runs the cardiac transplant program in AIIMS. And he is also one of the important figures for heart failure in India with multiple publications. He is also the editor of the prestigious journal published by AIIMS, the Journal in Progress in Cardiovascular Diseases. And Dr. Krishnamurthy, our head of the department and professor of cardiology, who is a renowned pediatric cardiologist. So he is also chairing the sessions. Over to both of you for taking on the session.
So for this session, we'll be having two case presentations, one on acute heart failure, one on chronic heart failure, then a session on patient education and behavioral therapy. So I think let's have the presentation on acute heart failure first, and then we can start discussing and taking up questions from there.
Yeah, Sandeep,
So
if you want to stop, Sandeep, if you want to stop in between the case and start discussing, that also is okay. So
yeah, we'll do that as per need.
Okay.
Recording in progress.
Sudesh, please go ahead.
Acute heart failure by case. Four-year-old gentleman whose occupation is a painter. He is alcoholic and smoker since the past 25 years. He is a newly registered diabetic and non-hypertensive patient. He had progressive exertional dyspnea for 1 month, presented with worsening of dyspnea associated with orthopnea and paroxysmal nocturnal dyspnea and pre-syndrome. He was having no history of angina, palpitation, or reduced urine output. He was admitted and evaluated at the local hospital where he was diagnosed as dilated cardiomyopathy with severe LV systolic dysfunction, mild pulmonary artery hypertension, atrial fibrillation with fast ventricular rate, and diabetes. He was stabilized and discharged on TAB Lasix 40 mg, 20 mg, 20 mg, TAB Aldactone 25 mg OD, TAB Carvedilol 3.125 mg BD, TAB Ramipil 2.5 mg OD, TAB Warfarin 2 mg OD, TAB Digoxin 0.25 mg OD, and was advised on diet control for low sodium, low fat, and low sugar diet. After 15 days of discharge, patient had persistent functional class 3 dyspnea on exertion and had bilateral lower limb swelling. Repeated OPD visits were futile, and hence patient was referred to SCT-MST for expert management. He presented to us with class 3 dyspnea on exertion with orthopnea. Patient had abdominal distension, ascites, and bilateral lower limb swelling. No history of palpitation, chest pain, or recent fever history. His vitals was heart rate was 112, rhythm was atrial fibrillation. Patient was tachypneic with a respiratory rate of 32. BP was 90/72 and saturation was 94% on room air. Clinical examination revealed normal appearance, no pallor icterus clubbing sinuses, but pedal edema was present. Cardiovascular pulse rate was 113, highly irregular. All peripheral pulses were palpable. JVP was elevated 10 centimeter above clavicle. Precordial cardiomegaly was there. S1 was variable. S2 was normal. LV S3 was present. No S4, no murmur. Respiratory system on auscultation, there was bilateral basal crepitations present. GIT on palpation was soft, non-tender, but hepatomegaly was present. Minimal ascites was there. CNS examination was normal. GCS was E4, V5, M6. Patient weight was 74 kg and height was 167 centimeter. ECG showed atrial fibrillation with a fast ventricular rate, occasional VPCs, QS in V1 to V3. X-ray revealed cardiomegaly and cardiothoracic ratio was 64%. Echo showed LV dimensions of 60/56, septal was 10/10, and posterior was 11/10, and ejection fraction of 14%. Hence, we can see that patient heart is a grossly dilated heart with a reduced ejection fraction. And echo showed mild to moderate mitral regurgitation, severe tricuspid regurgitation, global left ventricular hypokinesia, and TAPSE score was 12. Patient was put on a diagnosis of dilated cardiomyopathy, and etiology was taken as alcoholic. Since the patient was a chronic alcoholic for the past 25 years, first etiology we thought was of chronic alcoholic. Second etiology we thought it will be tachycardiomyopathy, since patient presented to us with tachycardia and atrial fibrillation. Third etiology we thought it will be ischemic, because patient was a chronic smoker. He was a male and aged 44 years. So smoker, smoking history was there. Since we thought the etiology will be ischemic. Patient had severe biventricular dysfunction, heart failure with pulmonary edema, mild to moderate MR, severe TR, mild PH was there. ECG revealed atrial fibrillation and it was having fast ventricular rate. So patient was admitted to heart failure ICU with a vitals of heart rate 113, respiration 34, BP was 98/73. Saturation was 94. So initial plan was to stabilize the patient. We followed the protocol of ABC. For airway clearance, we put we put the patient on non-invasive ventilation with a spontaneous CPAP mode with 40% FiO2 and PEEP was kept as 5. What non-invasive ventilation does is it works by increasing the ventilation. It decreases the preload and afterload, and it decreases the work of breathing, and it improves the gas exchange. It increases the thoracic pressure, which in turn will help to decrease the preload and afterload by decreasing the venous return to the heart. In addition, patient's PEEP was kept at 5 so that fluid can be shifted from alveoli to interstitial space. Fluid can be shifted back from alveoli to the interstitial space back to the circulation. Next, patient for diuresis, injection Lasix 40 mg IV stat was given of over 10 minutes, followed by 5 mg per hour infusion. So what we practice is we don't give Lasix. As you all know, Lasix is a potent ototoxic drug. We don't give Lasix as the rapid IV bolus. We have to give Lasix slowly over 10 minutes. Otherwise, it will cause permanent irreversible hearing loss. Also, and followed by 5 mg per hour infusion that ensure the consistent delivery of Lasix infusion without causing further toxicity. And his intake was reduced to 1.5 liters per day, and he was asked to monitor pulse rate, saturation, BP. He was catheterized for hourly urine output, and tab digoxin 0.25 mg was given to control rate. Patient was already on beta blocker, tab carvedilol 3.125 mg PD. It was continued. Usually in acute decompensatory heart failure, we don't initiate beta blocker. Since patient was already on beta blocker and his rate was high, tab carvedilol was continued. Patient stabilized and reassessed. His samples were sent for lab investigation. By the meantime, lab result came. Electrolytes were normal. Serum sodium was 136, potassium was 3.5, calcium was 9.1, magnesium was 1.9, and creatinine was normal 1.1. But his PROP-T value was 0.014 nanogram per ml, but NT-proBNP was highly elevated, 8,670. And his complete CBC revealed HP of 15.5 and total count of 6,600. Hence, we explored the probability of an infective etiology. LFT, urine routine, UST abdomen were normal. TRBS was 132. PT-INR was elevated 3.29 since patient was already on warfarin. Since the RFT was normal, we started tab aldactone and tab ramipril. Tab aldactone 25 mg OD, tab ramipril 2.5 mg OD, and insulin given according to RBS. But patient was euglycemic throughout the hospital stay, so there was no need for giving insulin. His intake was 1000 ml and output was 3000 ml. So patient was still on NIV. We initiated weaning from NIV. Patient FiO2 reduced to 30, PEEP was 5. Weaning from NIV initiated with intermittent oxygen at 6 liters per minute. By evening, we were able to wean off the patient entirely from NIV, and he was maintaining his saturation on oxygen at 4 liters per minute. Tab Lasix infusion was stopped and started on tab Lasix 60 mg and 40 mg at 7 a.m. and 3 p.m. As we all know, Lasix acts for 6 hours. If we give patient late at after 4 o'clock, that will cause nocturia and it will cause sleep disturbance to the patient. Patient has to wake up in midnight for passing urine. So we usually practice, we give the last dose of Lasix tablet for injection before 4 o'clock. And day 2, his vitals improved. Initially, his heart rate was 113, it decreased to 103, rhythm was still AF, and respiration decreased, BP, and saturation was 100% on 4 liters of oxygen. Day 2 lab result revealed serum rest were normal, only serum, so potassium was 3.2. Since the patient was extensively diuresing, there will be lot of loss of potassium through urine. Hence, potassium replacement initiated and serum potassium 10 ml BD. Tab dapagliflozin 10 mg half OD started. Already Harishman sir has explained regarding dapagliflozin. Dapagliflozin is an anti-diabetic drug which has added effect on heart failure also. What it acts in the, it is a sodium glucose co-transport inhibitor that lowers the plasma glucose levels in patients with the type 2 diabetes. But along with it causes glycosuria. But along with excreting glucose, sodium is also excreted. So patient will have the added benefit of diuresis, natriuresis, glycosuria, and it helps to decrease the preload and afterload. It also helps to decrease your systemic blood pressure by decreasing the blood volume. It also decreases the arterial stiffness, so thereby decreasing the workload of heart. It also decreases the volume of blood by it. So it decreases the preload. It also helps to decrease the body weight, hyperglycemia, and glucose toxicity and insulin resistance. On day 2, patient intake was 1100 ml and output was 2300 ml. Day 3, patient was on intermittent oxygen at 2 liters per minute and patient was on room air. Patient orthopnea improved. Patient was able to lie supine. His vitals were normal. Heart rate was 85, respiration 24, BP was 96, 77, and he was maintaining 100% saturation on room air. Lab results were normal. PT-INR was 1.2, and patient shifted for diagnostic coronary angiogram. And diagnostic coronary angiogram revealed LM, LCX, and RAMS was normal. LAD, there was a type 3 vessel, and proximal LAD has a mild disease, and there was no flow-limiting stenosis in LAD. RCA, there was a mild plaque in mid RCA, no flow-limiting was there. So impression was a mild CAD, and hence patient was put on medical follow-up. And cardiac MRI was planned later to look for ischemia and viability of LAD territory and look for evidence of myocarditis. Day 3, patient was hemodynamically stable post CAG. Sheath was removed, distal pulses were palpable. Patient was on room air. Catheter was removed and patient shifted to ward. Day 3, patient intake was 1300 ml and output was 2800 ml. Day 4, patient was on ward. He was stable. His vitals were heart rate was 72, respiration 22, BP was 176. And lab result revealed PT-INR was 1.8. So TAP warfarin 2 mg OD started because patient was already on atrial fibrillation. Atrial fibrillation predisposes the patient for clot formation, and if the clot dislodges, it may cause stroke. And if it occludes any place, it will cause stroke. So in order for stroke prevention, it started TAP warfarin. Patient was already on warfarin. And day 4, his intake was 1200 ml, output was 2000 ml, and patient weight 68.7 kg. Ideally, any patient with heart failure should be taken. Daily weight monitoring should be done. But for this patient, we were not able to do weight monitoring for the past 3 days since patient was unable to stand. Day patient was on NIV. Second day, femoral CAG was, day 3 femoral CAG was. So patient weight was taken on day 4 and his weight 68.7 kg. These were stable. Lab results were normal. PT-INR was 1.6. TAP's sacubital valsartan. It's an angiotensin receptor neprilysin inhibitor. Patient had already lost 6 kg of body weight. His was 1 kg on day 5. Day 6, patient's vitals heart rate improved to 20 per minute. We plan to maintain the INR between 2 to 3, and here with the initiation of warfarin, patient INR improved to 2.2. Same creatinine was normal, and he was planned for discharge. Day 6, his intake was 1400 ml and output was 2200 ml, and his weight was 68 kg. He was put on diagnosis of mild pulmonary artery hypertension, atrial fibrillation with controlled ventricular rate, and diabetes. He was given a discharge advice of TAP Lasix 40 mg, TAP 50 mg PD, and he was asked to monitor his RFT and serum potassium regularly. TAP dapagliflozin 10 mg OD, and TAP warf 2 mg at 5 p.m. And he was asked to regularly check his INR, and he should keep his INR between 2 to 3, and he had to titrate his drug accordingly in consultation with heart failure clinic. He was put on a fluid restriction of 1.5 liters per day. He was advised to stop his alcohol and smoking. Low fat, low cholesterol, salt restricted diet was advised. Regular BP and sugar monitoring in the nearby hospital, and he was advised regarding maintenance of daily intake output and weight chart. He was asked to review SOS for after and 1 week in OPD. So initially patient was stabilized and discharged, and his first follow-up after 1 week revealed vitals of 75, respiration was 18, BP was 172, and saturation was 100% on room air. His PT-INR was between 2 to 3, it was 2.4 only, and creatinine was 1. And currently NYHA classification, he is in a class 2 heart failure. No worsening was there, no dyspnea, paroxysmal nocturnal dyspnea, palpitation or ascites was there, but mild pedal edema was there. And his echo revealed LV ejection fraction, LV of 58 by 48, septum was 11 by 10, posterior was 11 by 10, but his ejection fraction improved from 14% at admission to 20% now, and his TAPC score was 13. So first of all, since patient had pedal edema, his tab Lasix dosage increased to 60 and 40. Tab aldactone 25 mg, tab carvedilol 3.125 mg, tab digoxin 0.25 mg, and the rest were continued. And he was advised to review after 1 month in heart failure clinic. So patient was on regular follow-up in heart failure clinic. Patient attended heart failure clinic on 1st, 3rd, and 6th month post-discharge. Drugs were up-titrated to maximum dose during subsequent visit. His beta blocker tab carvedilol was up-titrated to maximum dose of 50 mg. His Arni group of drug tab sacubitril valsartan was up-titrated to maximum dose of 200 mg. His MRI group of drug tab aldactone was up-titrated to maximum dose of 50 mg. And SGLT2 inhibitor tab dapagliflozin was up-titrated to maximum dose of 10 mg during subsequent visit. The patient was maintaining strict drug adherence, proper lifestyle modifications, and he improved significantly. On admission, his ejection fraction was 14%. 1 month after discharge, his ejection fraction improved to 20%. 3 months, his EF improved to 33%, and 6 months after discharge, his EF was 48%. We can see there was a considerable improvement in the patient condition. Initially, his body weight was 74 kg, which reduced to 68 kg. And 3 months after discharge, it was around 65 to 66 kilogram. And patient was maintaining an ideal body weight. And we can see ProBNP at the time of admission was 8,670. 1 month after discharge, ProBNP was not done because it's a costly investigation. Here it cost almost around 1,400 rupees. So after 3 months of discharge, ProBNP was repeated, which was 4,770 picogram per ml. And after 6 months of discharge, his ProBNP improved to 870 picogram per ml. So by EF wise, body weight wise, and patient was properly improving. He was able to resume his work, and patient improved significantly. So implementation of a protocol-based follow-up help us to improve the quality of life, reduce readmission and mortality rate in heart failure patients. Thank you.
So that's a very good case that you presented, very well managed. The best way to discuss this would be that you start from the first slide where the patient was managed before he came to Sri Chitra. Can you show that slide first? Dr. Krishnamurthy, and I can take it up from there.
Yeah,
Just
please
present the slide where the patient was given treatment outside the Sri Chitra hospital. Start with that slide. So he's alcoholic, he's 44-year-old. Yeah, okay. So he's discharged on this therapy.
Next slide.
One thing I want to ask you is, you have written newly detected diabetes. Okay, go on now. Let's see the slide.
Go
Show
to the
the
second slide. When
Go to the second slide where the management is started.
next one.
Yeah. Okay.
Next.
Next one. Yeah, come to the next one. Okay. No. Keep it on the treatment. Keep it on the treatment.
Back.
Slide.
Go to the second slide of the back. That one. Next one. Next. Okay. Make it into full screen. Yeah.
Yeah, okay. So at this point, the patient has come with a short history of heart failure. He's a middle-aged person around 40, 45 years of age, and he's been given a fairly high dose of diuretics, aldactone, carvedilol, ramipril, warfarin, digoxin. So if you look at this, my first thing would be that the things which are missing, one is there is nothing about diabetes management. At some point, you would also want to give dapagliflozin, but see, after the patient is initially stabilized, we do expect that many of these patients are likely to destabilize in the first 1 or 2 weeks after stabilization, which is what has happened to this patient. The second thing is that at this point, he was given a fairly high dose of digoxin, 1 full tablet every day. So that is something you have to be very careful. Most of us would be giving half a tablet 5 days or 7 days a week. So that way this dose for digoxin is a high dose. Now, would anyone like to say amongst the nurses, what happens if you give a high dose of digoxin? Can the nurses respond? Can we see the responses?
Digoxin toxicity.
Yeah, so what is the digoxin toxicity that you fear? what is the digoxin toxicity that can occur? So the commonest side effect that we expect from digoxin is loss of appetite. That is not something to worry about too much, but if you don't pick it up at that stage, the next thing that will occur will be arrhythmias. So we have to think the commonest is the appetite loss. The most dangerous that you're worried about is various forms of arrhythmias. They can be bradyarrhythmias, they can be tachyarrhythmias. Just about every possible arrhythmia can occur with digoxin. So that is one thing with digoxin. Then at this point, you do expect that patient would have worsened, which is what has happened. Can you have the next slide, please? Could you go to the next slide?
Next slide. Can you show the next slide? Sudesh.
So we have.
Please go to the next slide.
Acute issues.
Yeah, so after no, just
one,
move
yeah.
it slowly. Just keep it here. So see, this is what has happened. He has stayed stable for 2 weeks and then he started worsening. He's had pedal edema, then he had repeated visits to the local hospital with no improvement, then he comes to Sri Chitra. So this is the point where if the patients are educated properly, that moment they start having a gain in weight, that means if they're gaining about half kg to 1 kg every day, and they start developing lower limb swelling, that is the point where they have to rush to the hospital or phone their doctor, and their diuretic doses have to be increased drastically. So because this is a simple warning sign which occurs in most patients. Next slide. Yeah, so now he's become class 3. He has abdominal swelling, ascites, bilateral pedal edema. Show the vitals. Yeah. So at this point, supposing he was in the OPD, you don't want to admit, or for instance, we very frequently don't have beds to admit. So we have an AF with a heart rate of 112. Respiratory rate is going up, his saturation is going down. See, if his saturation had been okay, possibly we could have tried managing this patient on an OPD basis if there was lack of beds, as we frequently face. So at this point, now the thing that we can do for heart rate control, starting with heart rate control, you already have the patient on digoxin. An alternate can be that you can consider very carefully defibrillating this patient, because we don't know the duration of history, but as of now, our history is about 1.5 months. So that can be considered only if you find that the echo shows that there is no clot in the heart and the LA is not very big. If the LA is very big, if the LA is 40 millimeters, 50 millimeters, you know that this is a chronic thing. So you defibrillate, the AF will come to sinus rhythm and it will go back to AF very fast. But supposing your LA size is normal, you're very clear the patient did not have AF prior to your seeing the patient, then you can consider defibrillating the patient. The second option in terms of medical therapy is that you can add amidron. Amidron and digoxin is a very dangerous combination, but at that point, you can consider slowly removing digoxin and adding amidron in an oral loading and gradually build up the thing, because that is the only antiarrhythmic that you can actually give in heart failure. Blood pressure is down. So another thing you can do is at this point, increase the diuretics and perhaps keep going up till the patient improves. But with this saturation, obviously you have to think of considering admitting the patients for any form of ventilation. Go on to the next slide. Yeah, so this is the same thing. Next slide. Okay, so here what you should note is that his weight at admission is 74. By the time you optimize everything, stabilized him, and went through 6 months of therapy, his weight has become 65. So 65 is his dry weight. That's at the end of the presentation. So he's got excess of weight of 74. That means it's all water accumulation. So that's one thing you should pick up from here. Next. So now this is very important. I always teach all my nurses also that as far as the nurses are concerned, they don't have to try and learn how to read all ECGs properly, but they have to learn two things. One is that most of the current ECG machines on the top, they have a report written. So learn to read the report. We don't expecting you to become experts on ECG reading, but you can easily read a report. You'll get to know what is the heart rate. You don't have to worry about calculating the heart rate. As far as seeing the ECG, two things which are important is one is that patient has AF or not, because the moment you have AF, you have to get rate control, and you have to get an anticoagulation on. Supposing your physician has missed anticoagulation, you can easily tell him to start considering anticoagulation. Second thing is a left bundle branch block. So even if you can recognize just these two things, a left bundle branch block and an AF, you can make therapeutic changes in the patient's management. If there's a left bundle branch block, this patient, if he doesn't stabilize, in the long term, he will be a candidate for a CRT or a CRT-D. So these two things you should always look for and write down on your notes: patient in sinus rhythm or patient in AF, patient has or does not have a left bundle branch block. So I think these two things are very important. Next. Here again, the two things is that, again, the nurses need not become experts at reading X-rays, but you should know what a normal X-ray looks like. So you know that the normal X-ray has a CT ratio of about 50%. So here, obviously, there's a heart which is grossly enlarged, and the lungs, which should be black, have become white. So just remember this much, that this is not a normal X-ray. Heart is looking big and lungs are whitish. You should also know that often these patients will have complications. So you should learn how to recognize other things. For instance, suppose there's a white patch somewhere, you know it's patient has pneumonia, or if there's a black line and a black box somewhere, could be having a pneumothorax. Or if the CP angles, which here are sharp, become filled up, then pleural effusion. So three things which currently you can miss clinically in a patient with AF, in a patient with heart failure, and which will have therapeutic decision changes. So those things you should pick up skills for picking up on an X-ray. You don't have to worry about more subtle things, but this much is sufficient for you as a nurses handling heart failure. Next. So, okay, this is the echo at this point. At this point, I would like to know maybe two more things from whoever's done the echoes. One is, what is the projected PA pressure? Because that would, the patient has severe TR, but is it a functional TR? Is the TR because of a high PA pressure? And also, I would like to know the IVC. What is the IV normal? Is it collapsing? Is it dilated? Because that will give us an idea of what the exact fluid status of the patient. And also, what is the RV function is a very important and good prognostic marker. Supposing this patient has a good RV function versus a patient who has a poor RV function, I would know that the patient with a good RV function is more likely to do better. So do we have any information on that? On the IVC and the PA pressure? It doesn't matter. You can go on to the next slide.
Go to the next slide, please.
Go to the next slide. No, previous one. Yeah. No, keep it the diagnosis, right? So keep it here. So this basically is a middle-aged gentleman who's come with a short history, dilated. The echo shows dilated cardiomyopathy, and obviously you have looked for possibly correctable causes. So alcoholic does become very important. Tachycardiomyopathy, that is something you always think of in any patient with AF. Ischemic because he's above 40. I would like to add at least one or two more things here. One is that I would actually think of myocarditis as a possible cause at this stage. Because if the history is very short, it looks like a DCM, and there is no regional wall motion abnormality, the ECG does not show an infarction pattern, then I would actually want to actively rule out myocarditis at this stage. So that is one thing you have to think of. You have to look for inflammatory markers. You have to look for any subtle changes in the ECG ECG, are there any STT depressions? So those subtle things, is there a past history of some upper viral illness 2 to 3 weeks prior to the current illness? So those things in the history can possibly add to your management. The rest here is same. Okay, next slide, please. Okay. So at this point, saturation is down. You've taken up the patient on NIV. Now, would you like to comment on the NIV parameters? How do you set the NIV parameters in a patient with heart failure? What are the concerns? Sudesh, would you like to comment on that?
Okay, FiO2, if some patient saturation is less than 85, we try to keep a higher FiO2, but preferably if saturation is above 90, we usually keeps FiO2 around 40% only. PEEP, we usually keep at 5 to 7. More than 7 PEEP, if anesthetist indicates only, then we will keep the PEEP more than 7. We usually keep the PEEP between 5 to 7 only. And initially we.
So what is the concern with PEEP? What happens with PEEP? Positive things and negative things.
So PEEP, it's like a double-edged sword. It will help in the fluid shift from alveoli to the interstitial space back to the circulation. PEEP will help that. It also increases the intrathoracic pressure, so that the venous return will be reduced, and the preload and afterload both will be reduced. Initial NIV gives the patient. It reduces the work of breathing of the patient. But if we increase too much, there is higher rupture of alveolar rupture, and patient may may precipitate atelectasis.
More important is that if you raise the PEEP up very high, here the patient's blood pressure is borderline. So if you reduce the venous return also, the blood pressure can fall, and that can become a major issue with these patients. So you have to be very careful about increasing the PEEP very, very slowly. And if the BP starts falling, then sometimes you have to give NIV without any PEEP. That is a major concern that you have to be very careful about. Next slide. Yeah, so at this point, you have given a shot of Lasix 40 mg followed by 5 mg per hour infusion. Now, would you like to discuss why you would prefer to give an infusion versus bolus therapy, or it does not matter? Would you like to take up that discussion? Which is preferred, an infusion or multiple bolus shots?
Sorry, infusion will be preferred because it will give a persistent low dose of Lasix to the patient. It won't cause any side effects like ototoxicity, and patient will be maintaining a persistent diuresis will be maintained. And there won't be any BP fall. Since this BP is in borderline, sir, we have given that 40 mg Lasix as a ideally, if the BP is below 90, we have to give the 40 mg bolus in a divided dose. Sometimes if the BP is very low, we have to give that Lasix in a 10 mg, or 20 mg like that. And so if the BP is low, we prefer infusion only, sir. But since he was very tachypneic, we have to initially give that 40 mg bolus, and we have to closely monitor the BP for first 1 hour for every 5 minutes. If there is a BP fall, then we have to initiate him on dopamine or dobutamine. So we prefer infusion also.
Yeah, so that's partly correct. That normally this is what most of us, I think, would be doing, that we would give a shot of Lasix. In this case, you've given 40 mg. Now, perhaps if the patient had not responded to 40 mg, the guidelines generally say that you should give at least equal to or a higher dose of Lasix as compared to what the patient was on. So the patient was on almost 80-100 mg of Lasix a day. So starting with 40, being judicious because the patient has hypotension. And if 40 doesn't work, after 10 minutes, you can give another 40, because it will cause hypotension ultimately by causing a urine output also. So you can reverse that very easily. As far as infusions or boluses are concerned, people keep arguing, and there are multiple studies that both are equal. But in the initial stages, most people would prefer to start an infusion because it is relatively easy to titrate. You started something, you don't have to worry about that. And if the urine output opens up with the bolus shot, then you can easily maintain it by the infusion, which you can keep increasing and decreasing as per the urine output. And you want, in an adult, you would want at least 40-50 ml of urine per hour. That is a rough thing that you have to use. You don't have to worry about trying to make a calculation. Then you done fluid restriction, you monitored everything, early urine output, digoxin continued. I am a firm believer that at this point, beta blockers should be stopped. Because even though there are studies that you should continue beta blockers, this is a patient who is decompensating. His blood pressure is borderline. He's reached a ventilator. Had he not reached a ventilator, he was stable, he was easy to manage. Perhaps you can have an argument on continuing beta blockers. But I personally, at this point, stop beta blockers. What would Dr. Krishnamurthy and Dr. Hari Krishnan want to think at this point?
It is
Yeah,
please.
Yeah, sir, please go ahead.
Yeah, it is debatable. It's a personal opinion. It is already tolerating, it can be continued.
The two things is heart rate was also on the higher side. Probably that is why it was continued. Two things. And he was already on this dose, and the heart rate was on the higher side because already patient is on digoxin. Otherwise, we had to go for amiodarone. That is why probably they must have given continued on relatively lower dose of carvedilol.
Yeah, so as I said, we can debate about this, but the guidelines generally say that you should continue beta blockers if possible. Here, of course, you wanted to try and control the heart rate also. So that way, maybe continuing carvedilol and taking a call that if the patient worsens in spite of all the initial management, you can consider stopping it later. So go on to the next slide. Yeah, so if you see this, if you look at the data, his electrolytes are fairly okay. His kidney function is okay. That way you're hopeful that whatever heart failure decompensation he's had, his kidneys have not been affected. Troponin slightly elevated, not very high. BNP, you do expect the BNP to be very high. At this point, the BNP gives you an idea of the prognostic state of the patient. The best thing is if you have a BNP, what we generally do is we don't do, as you said rightly, the BNP is costly. It has to be paid for. So at this point, possibly you can avoid doing a BNP. You can think of doing a BNP when you're ready to discharge the patient, because that is more prognostic. Here you do know that BNP will be very, very high anyway. So that will not be helpful. Hemoglobin is 15. Normally we would want to have an idea of the ferritin, also look at the RBC markers, but at 15, we don't expect much of iron deficiency. So we are basically at this point trying to look for anything else that we can gradually correct at this point, besides the heart failure management that you're doing. Counts are also fairly okay, though the polymorphs are slightly more. ESR is not very high. So ESR, in spite of everything, is not very high. So very, very soft thing, not very sensitive, but that means inflammation does not seem to be a very important marker. LFT normal again. So LFT, RFT normal, I always think of it as a good sign that at least whatever is happening to him, it's not affected the kidneys and livers at the same time. So that's a good thing. Blood sugar is high, HbA1c is relatively high. So go on to the next slide. Now, at this point, he's been started on Aldactone, Ramipril, insulin according to random blood sugar. Aldactone, I accept. Ramipril is something which, in a patient who's on a ventilator and Lasix infusion, is perhaps discussable and debatable. Whether you want to, at this stage, still give a relatively high dose of Ramipril, or if you just want to give a vasodilator, maybe give a gentle dose of infusion of NTG. Once the patient is stabilized off the ventilator, then you can think of adding Ramipril. Because once you've given a single tablet of Ramipril, the effect will last for at least the next 12 to 24 hours. You will not be able to reverse the effect very easily. Supposing the patient at Ramipril 2.5 goes into hypertension. What do you think, Dr. Hari and Dr. Krishnamurthy?
I fully agree.
Yeah, I also agree. We have to be. I think probably we could have started at 1.25 milligram and then slowly built up. 2.5 milligram of Ramipril is a rather strict dose.
So after that, let's go on to the next day. So at this point on NIV, you brought on the FiO2 and PEEP is staying the same. Patient gets stabilized, is off NIV. And Lasix infusion stopped and bolus Lasix started. So that's perfectly managed. BP is still borderline, is below 100. Saturation is now okay. That means most of that desaturation was actually due to pulmonary edema, which is now settled down. So there was no definite infection over length. So probably giving a single antibiotic to most of these patients is not harmful. AF also, the rate has come down relatively. We're not very aggressive at this stage in trying to control the heart rate. We just want it to be reasonable. So even 90 to 100, 105 as an initial target is fairly okay, because you have time once the patient stabilizes to improve the heart rate control. Next slide, please. Go on to the next slide, please. So they try for the next slide.
Next slide, please.
I'd just like to add that if at this stage the patient is not improving with his diuretics, addition of another class like metolazone, which has a different site of action, may also be helpful.
That's a very, very good point, that adding multiple types of diuretics can actually improve the diuresis. So you would want to add metolazone at this point, which is basically a thiazide type of diuretic, the only thiazide which is actually useful in heart failure. So you can do that. If after all that the patient still doesn't pass urine adequately, then you can think of things like ultrafiltration. But obviously in this patient, the diuretics were working. So you don't have to think of going beyond medical therapy. So Desh, can you try to change to the next slide?
Can you please go to the next slide? Any issue there? Sudesh.
So subsequently, after the initial management, the patient was having an initial diagnosis of either alcoholic tachycardiomyopathy. Yeah, okay, fine. So this time now, obviously with a diuresis of 3 liters a day, he has gone into hypokalemia, which does happen. So adding potassium is the correct thing. As nursing officers, you have to always remember, though I'm sure you all know anyway, that potassium has to be given in a diluted form. So, and patients don't often tolerate oral potassium very easily. So perhaps at this point, you can also consider increasing the Aldactone dose. That can sometimes control the fall in potassium, and you don't have to add oral potassium at the same time. Can you go on to the same slide? Okay, so at this point, patient has improved and he's gone for a coronary angio. Next slide, please.
Next slide, please. Somebody be on the.
Yeah, okay. So anyway, when the angio was done, there was no significant coronary disease. The LED showed a 50% lesion, and otherwise the rest of the coronaries were normal. And he was planned for an MRI, but I think the MRI, if the MRI was done, we would like to know what happened in the MRI. That is one thing, because we are suspecting a possible myocarditis in this patient. Though looking at evidence-based medicine, you will not make a change in the therapy. You will not think of giving immune suppression. You will not think of giving anti-inflammatory, since the patient is improving. But it is important, supposing a patient was not improving, and your patient was worsening, then you would think that this could actually be active fulminant myocarditis. So I would, in that stage, that patient will not be in a stable condition to do an MRI or even a biopsy. So there, electively, I would think of maybe giving him a few shots of steroids and even IVIG. We have done that. Dr. Krishnamurthy would have better experience with handling pediatric patients because pediatric patients with DCM and acute onset DCM respond much better to immune suppression and IVIG. Dr. Krishnamurthy, would you like to comment on that?
We have encountered a few cases like that, and they rapidly respond to these IVIG and steroids. You're right.
Yeah, because I think the children's hearts have not yet lost the capacity to repair itself and perhaps even regenerate itself. Because when we were starting a stem cell program, we were trying to understand the anatomy of the heart at different stages. So there is a lot of data, both from human studies and also a lot from animal studies, that the growing heart, the children's hearts are somewhat different. So there you do find islands of stem cells, you find lots of capacity to repair itself. So possibly that is why the children respond better to things like immunoglobulins and immune suppression. So that is one thing, but we do give it in adults also. There is no guideline on this. If you look at the data,
empirical.
It is totally empirical. So if you ask me to defend it in a debate, I will never be able to defend it in a debate. But yes, wherever they could actually pick up viruses, whenever they did the EM biopsy and they picked up various viruses. So they found that if you pick up a virus and you give him antiviral therapy according to that, for instance, IVIG is antiviral for viruses like parvovirus. For viruses like enterovirus, you have to give interferon. So small studies, mainly from Europe, have shown that if you give focused therapy based on a virus that you found, that set of patients will improve. But all the major trials where you have not looked at viruses, when they try to give immune suppression or they try to give antiviral therapy, they have not really found any suitable results, give any sufficient data to give any guidelines.
Yeah.
So
Giant cell myocarditis probably respond to immunosuppressives.
Yeah. So after that, the patient is given dapagliflozin, and we done. Can we have the next slide? Is possible now?
Next slide. Go forward.
Yeah, move after the angio. No, previous slide. Move very slowly. Just move very slowly. So okay, keep it here. So coronary angio was done as is required for all these patients because you can easily find something treatable there. MRI was planned. Do we have any information on the MRI?
Sudesh, can you say the MRI file just done later actually on follow?
Okay, fine. So go on to the next slide. Let's have the next slide, please. Okay, so angio done, sheaths removed, patient is stable, go on. Okay, so at this point, the management is correct, saturation is picked up, patient is doing well. Next. Go on to the next slide. Okay, next. So warfarin has been started. You can think of giving one of the NOACs, also one of the newer anticoagulants can also be considered, but warfarin is good enough. So day 5, sacubitril valsartan has been started. So ARNI has been started on day 5. It's a good way to start that you give half a tablet twice a day. We sometimes start half a tablet once a day. And you have to be very careful that before starting sacubitril valsartan, you should have stopped the ramipril dosing at least 1.5 days before that. So sometimes when you want to give an initial vasodilator, you can give a drug like losartan. The advantage of losartan in acute heart failure perhaps could be that when you want to switch from losartan to sacubitril valsartan, you don't have to give any gap. You just give losartan one day and the next day you can easily switch over to ARNI. We would normally start with half a tablet once a day, see the response for 1 or 2 days, and then go on to BD. And then once he tolerates the initial dose, the patient will tolerate the subsequent dose elevations also. So he's lost 6 kg of body weight, which is very good. Go on to the next slide. He's planned for discharge. Now at discharge, his creatinine is still stable, sodium is okay, potassium is okay, and INR is optimized. Now at discharge, what are the things that you're supposed to plan? One is the patient should be educated about self-management of heart failure. So the nurses have to sit with the patient, take them through the entire medication list, teach them about how each medicine can make differences in improving the patient, but at least they should know some of the common side effects of the medicines they are on. For instance, they should know that vasodilators, beta blockers will cause a fall in blood pressure. So if they get symptomatic hypertension, then they should contact the doctor, but they should at the same time not worry if the BP stays 90 to 100 and not overreact to that also if they don't have any symptomatic hypertension. Diuretics, again, they should be encouraged to eat potassium-rich sources. So things like coconuts, bananas, lemon. Here the patient is diabetic, so banana and citrus fruits go out, but at least they can take coconut water and lemon as potassium-rich sources. It makes them feel better also. And the potassium and other minerals which you lose at such high doses of diuretics are also to some extent replaced. Then one thing which I maybe missed or was not there, and this is the point when you can actually give the patients a vaccination. You can probably catch, because the patient is still captive under you, you can easily give a shot of influenza pneumococcal. Also now, we always check that have they got their complete COVID vaccination. So have they got their 3 shots? If they're not, then we try and give them at least 1 shot of COVID also. And as was rightly done, and you can go to the next slide, patient was called at 1 week after discharge because most of the complications will occur in the first month. So sick patients are advised to schedule their visits on a initially weekly basis and then increases. So at this point, patient has everything, including diabetes. Diabetes, you're only given dapagliflozin, which has possibly been given for heart failure. So at this point, one would want to question whether you want to add additional drugs for diabetes control. Go on. I think we're 11:30, which is the time allotted for the first case. So we'll go on to this rapidly. So this is perfect. High dose of diuretics, which this is one thing which you have to be careful. Sometimes, and this is more for the nurses especially, most of our residents are not careful about the switch from injectable diuretics to oral diuretics. They'll give 80 to 100 mg of IV diuretics. They'll switch to an oral dose, which is very low. So you should be very careful that the oral dose of diuretics, if it's furosemide, should be higher than the injectable dose, and you have to monitor the urine output after that. So ensure that the dose in the initial switchover of diuretics is very high. You can always titrate it later. The rest of the therapy is good. Higher dose of ARNI, dapagliflozin, and anticoagulants. Next slide. So at discharge, he's been told to stop alcohol, stop smoking, and follow a low cholesterol diet. One thing I would like to add perhaps at this stage is that if he has diabetes, we would perhaps want to give statins from a diabetes indication point of view. So he should be given statins. He should be also given high doses of vitamins if he's been a heavy alcohol user. So that is something which will help in his ventricular recovery. Next. So at follow-up, he's okay. He's class 2, no problem at this stage. Good. Next. Now his ejection fraction has improved slightly. RV function is still down, but TAPSE, which was 12, has become 13. Severe TR is still there. Go on. Next slide. So at this point, see, obviously the patient was at some point was worsening, so diuretic dose was increased. Aldactone doses can generally go up with this to maintain the potassium, but you have to understand you're giving so many drugs which move the potassium up and down. So sacubitril valsartan will increase the potassium quite often. So all these things have to be kept in mind each time you see the patient. Next slide. I think you can go on to the last two, three slides where the final management is on, because I think we have to then go on to the next patient. Just go on to the final slide where the ejection fraction is improved and what is the final medication. Yeah, so ejection fraction has gone up from 14 to 20 to 33 and then 48%. And BNP has come down dramatically. This clearly shows this is possibly a reversible form of heart failure. And so the point that I was making initially, that were we dealing with a patient of myocarditis, seems quite likely in this patient. So this is the way all patients of acute heart failure would be managed. Dr. Krishnamurthy and Dr. Harikrishnan, would you like to add something before we close this case?
I would like to just 1 or 2 points. Management of iron deficiency and thyroid dysfunction in this patient is also important. 2 things. Another thing is exercise rehabilitation. This patient fortunately returned to work very easily, but there are patients who are not easily able to return to work, and they may be the sole breadwinners. So exercise rehabilitation and their rehabilitation in terms of their work is also important. Especially,
correct. I think that is something which I missed, but rehabilitation of these patients is very important, both physical and psychological rehabilitation. They have to be, what happens is many of the doctors and even cardiologists who are not treating heart failure will tell, look, your EF is 20%, this is the end of the road, so we can't do anything. So that negative counseling for these patients should not happen. Because what I generally do, if the patient has an EF of 20%, I tell them, look, the previous patient had an EF of 10%. He's doing better than you. So you have to work harder. So he feels that, okay, the previous patient was looking quite okay. Then I also have some hope. So hope should be given to all the patients, because you don't know how many patients these will actually reverse. So many of these patients, heart failure, even if you can't improve the ejection fraction as it improved in this patient, psychologically, symptom-wise, most of these patients will improve once you give them optimized therapy. So you should always be positive in counseling of these patients. So psychological and physical rehabilitation is very critical. We should encourage them to take up whatever work they were doing initially to whatever extent possible. That is absolutely critical. Dr. Harikrishnan?
Yeah, I think behavioral aspects are also very important. I think we will discuss in one of the subsequent presentations. Depression and anxiety are very, very common in these patients, and we have to, there are some patients who are severely depressed, and that depression itself can worsen the heart failure. So if we find some signs of depression, I think patient in our heart failure clinic, they initially come to the heart failure nurse where they have I think good rapport with them, and many of the patients open up to them and share their anxieties, etc. Because we are so busy and we may not be able to dedicate so much time to each patient. So many of the patients we were able to identify some patients with severe depression and refer to psychiatrists and psychologists for counseling and therapy. And some of them have significantly improved in their outcomes, and they have had a good outcome in the form of in the psychological aspects. So that also we have to be, and a regular graded physical activity is also very important. I think that will give a confidence to the patient. Small physical exercises which we give them training in the heart failure clinic itself, like just very simple stretching, small steps, etc. That also helps this patient to recover to a good extent.
Thank you, Dr. Harikrishnan. Can we go on to the next case now?
Some two questions are there, I think. Sandeep, shall we take up?
Yeah.
So kindly explain the management of heart failure on patients with chronic kidney disease. That is one question. Can you take up that?
Yeah, so this is something very important. That's why I was repeatedly looking at the kidney function. Because if the kidney function is impaired, two things will happen. One is your diuretics will not work very well. Second thing is when you want to give your vasodilators, it will become a major issue. You will not be able to give drugs like ACE inhibitors or ARNI. So look, taking the first thing, if supposing, for instance, the patient has a compromised renal function, your first problem will occur with diuresis. The first step is obviously that you keep going up on the diuretic dose. You can easily go up to 40, 80, 100, even 200 mg of the Lasix shot, the first furosemide shot that you give to open up the diuresis. That's a diuretic resistance that you're trying to break. Once the resistance breaks and the patient starts passing urine, he will continue to pass urine. Here also you have to be very careful that the patient should not be overly dehydrated. So having an idea of the IVC, having an overall idea of the hydration status of the patient by looking at skin turgor, looking at the tongue, all those things, and he's taking the history of what was his intake in the past one day or so, all those things will be factors you consider when you decide the diuretic dose. Supposing instead of this and supposing you add metalazone to it, supposing you added both diuretics, patient does not improve in a patient with renal failure, the next step obviously is that you have to actively think of doing ultrafiltration or a proper dialysis as the case may be, because that will be very necessary. Though here, obviously with a blood pressure of 90 to 100, the nephrologist will be reluctant to start dialysis very easily. So probably you'll have to start a bit of inotropes to keep the pressure head high and then think of dialysis. Dialysis also for these patients will be a hemodialysis, not a peritoneal dialysis. So that is one thing. Then once the patient has stabilized, then CKD becomes an issue in terms of vasodilators. Up till a creatinine of about 2.5, which is a simple number to remember, you can give vasodilators. So you can give Ramipril, you can give Losartan, you can give ARNI. Though the cutoff for ACE inhibitors actually is 3 and ARNI is 2.5, I generally use 2.5 as a reasonable cutoff for both groups of drugs. So up to 2.5, you can give the vasodilators. Beyond 2.5, you think of alternate vasodilators. So that can be a combination of hydrazine and nitrate, which can be started in low doses and built up. And when the creatinine levels fall and the eGFR improves, then you can easily switch over to ARNI or ACE inhibitors. Same problem with drugs like dapagliflozin. Again, with kidney failure, they will not work. So only with the eGFR of 30, which would amount to a creatinine of about 2.53, till eGFR of above 30, you can give drugs like dapagliflozin. Below that, you are advised not to give these drugs. So that's the common critical things you have to look for in patients with renal failure. Is there another question?
One corollary to this. Well, while on treatment for these patients, sometimes we see a transient elevation of creatinine also. That should not hinder our, as long as the patient is decongested, we should not hold on this, withhold the treatment so that creatinine is not a major concern.
Yeah, I think especially with the SGLT2 inhibitors and there is a transient rise in creatinine and the renal depression, renal function that is expected, but subsequently it will improve. So some question on role of BNP administration in heart failure. Sandeep?
Yeah, so BNP, we have been commonly thinking of BNP as a marker. But BNP or Nesritide, as it's commercially known, has also been used as a diuretic agent, because if you look at the mechanisms of heart failure, BNP is part of the pathway which gets activated. So BNP rise causes natriuresis. So there have been trials where Nesritide and BNP have been used for heart failure, but overall the results have not been very positive. So BNP infusion is not currently used.
Yeah, another similar one on stem cell therapy. I think that also is on the what is the experimental stage. I think there is no.
Yeah, so stem cell therapy, the data keeps coming and going. We also did a lot of work on stem cells in dilated cardiomyopathy and during surgery. So there are some patients who respond very well. In fact, when we started the trial, we were quite skeptical about it. It's only when the 2-3 patients suddenly responded very well that we became very serious about it. So when we did a trial in dilated cardiomyopathy, we gave them stem cells from the coronary arteries and we blocked the coronary sinus during the infusion. And after about 3 to 6 months, we did an endomyocardial biopsy also. So that was a time everyone was thinking that the heart will regenerate. So we actually expected that there would be regeneration in the heart. So to be very frank, there was no regeneration in the heart, which is what the subsequent trials have also shown, that regeneration does not occur. We did find that there was slight subtle increase in vascularity. There was a subtle decrease in the fibrosis. So we had serial biopsies before and after. So there was a decrease in fibrosis, which is what the data also suggests, that if stem cell works, is going to work by remodeling and helping in the remodeling. We subsequently also labeled the stem cells and injected in the patient. We found that in the initial studies that all the stem cells in all the patients don't actually home onto the injured heart. So possibly that is also important, that the way we are injecting stem cells is through the coronary arteries. So perhaps they will not be homing in all the patients. And that is why perhaps the results are so variable. I think that is the status currently. People are trying different things at different stages. The results are variable, still experimental, so not an accepted form of therapy.
I think, Sandeep, I think we are short of time. I think, shall we go to the next case then?
Yeah, I think we should go on to the next case.
Next, I invite Mrs. Preenavi, Nursing Officer, SCT IMST, to present a case on chronic heart failure.
Thank you, Rajda. Here my patient, 20-year male, asymptomatic till March 2016. He got admitted in the local hospital with complaints of excessive fatigue, dyspnea, and cough, and rapidly worsening symptoms. He got diagnosed with dilated cardiomyopathy, severe LV dysfunction, moderate MR, intracardiac thrombus, heart failure, cardiogenic shock, ischemic hepatitis, acute kidney injury. He got stabilized in the same hospital and discharged. But later in the same year, he had two admission. June and July 2016, readmitted with acute decompensation. And he was referred to SCT IMST for further management and possible cardiac transplant. At the time of admission, here patient admitted on 31st July 2016 with complaints of abdominal distension and worsening of dyspnea with the features of congestive cardiac failure. On clinical examination, heart rate was around 117 per minute, sinus rhythm, BP 96/60, respiratory rate 28. Cardiovascular assessment S1, S2, LV S3, and systolic murmur was there. Respiratory system, bilateral crepes were present. Per-abdominal examination revealed ascites. USG abdomen revealed hepatomegaly with gross ascites. On blood evaluation, LFT deranged, SGPT 400 and SGOT 550. Creatinine 1.8. Hemogram and seroelectrolyte were in normal range. Patient was found to be the hypothyroid state, so started thyroxine. X-ray revealed cardiomegaly. Sinus rhythm with a rate 100, PR interval 160 millisecond, QRS duration 100 millisecond, and poor R wave progression from V1 to V4. Echo LV 70/63, EF 22, LA by AO 39/22, global hypokinesia, no focal thinning, severe RV hypokinesia, no clot, moderate MR and TR was there, no PH, trivial pericardial effusion. So impression, dilated cardiomyopathy with severe biventricular dysfunction. We managed patient in the ICU with the diuretics, first Lasix bolus followed by infusion, and started on Dobita inotrop, and that later tapered as per patient hemodynamic. AC inhibitor enalapril changed to ARNI after 36 hours. Beta blocker metoprolol XR 25 milligrams started. Ivabradine added as heart rate high, but patient was not beta blocker was not tolerating. Eplerenone 25 milligrams started, and patient stabilized and patient improved symptomatically. So we started on cardiac transplant workup. CAT study done, cardiac output 1.98, pulmonary vascular resistance 3.9, systemic vascular resistance 28, cardiac index 1.16. Interdepartmental consultations taken, blood investigations done. During that time, repeated decompensations occurred, and patient received injection levosimendan twice during hospital stay. And that time, again, we restarted Lasix infusion, beta blocker and ARNI down titrated for a time period and then slowly increased. But due to financial constraints, patient and family was not willing for transplant. After 45 days of hospitalization, he got discharged with stable hemodynamics. So our plan was medical follow-up and follow-up in heart failure clinic. At the time of discharge, patient was advised to take TAP Diato 10 milligram BD and Eplerenone 25 OD, digoxin 0.25 of 5/7, thyroxine 25 microgram OD, ARNI 50 milligram BD, metoprolol XR 25 milligram OD, TAP Ivabradine 5 milligram BD, and advice strict fluid intake of 1 liter per day. Salt restricted diet was advised, and review in heart failure clinic after 1 week or as and when required. Our follow-up in heart failure clinic that done in a systematic way, first assessing the symptom. Is there any worsening of symptoms like angina, dyspnea, paroxysmal nocturnal dyspnea, palpitation, or fatigue? And assessment, especially weight, height, BMI, that is body mass index, and then heart rate, BP, saturation, and signs of both pulmonary as well as systemic congestion. Then investigations, usually RFT, LFT, hemogram, and proBNP. And according to patient situation, we summarize the condition and plan and treatment suggest accordingly. So the titration of medicine done as per patient presentation. The first follow-up after discharge, in the first week after discharge, for my patient, there were no worsening of symptoms. Fortunately, some improvement was there. The patient weight was at the time of first follow-up, patient weight was 55. At the time of discharge, it was 58. So some reduction in weight was there. Height 169, BMI 19.26. The ideal weight for this patient 69 kg, heart rate 92, BP 106/70, no ascites, saturation 98. Blood investigations were in normal range. The plan was up titration of beta blocker. So here we increased TAP metoprolol 50 milligram BD from 25 to 50 milligram OD. And fluid increased to 1.5. Advised to continue exercise as advised. And patient was on continuous follow-up for last 6 years. So 2 weeks after discharge, heart rate 96, BP 168, TAP metoprolol again increased to 100 OD.
Slides are not moving.
Later, heart rate 89, BP 96/60, TAP Ivabradine increased to 7.5 milligram BD. Is it visible now? Sir?
They're visible, they're not moving forward.
Yes, not advancing.
Now I am discussing about follow-up after discharge. First month after discharge. Is that slide is visible or not?
Visible. Please go ahead.
The visible.
The first-
Carry on. Carry on.
TAP ivabradine increased 7.5 milligram BD. Thank you, sir. Army, we cannot increase due to low BP. At that time, BP was 96/6. That time we done echo, and echo revealed LV 66/52 and EF 35. First, at the time of admission, patient EF was 22. So here, gradual improvement in EF. Month, heart rate 96, BP 110/60, saturation DA. Increased medulla BD dose, that is 150. On fourth month, heart rate 76, BP 108/76, TAP Army increased to 100 BD. And TAP
Your slides are not
milligram
moving.
changed to TAP
Reena, slides are not
25.
moving. Slides
This
are not
is
moving.
the reason is patient Sir, is it visible?
Yes, now.
They're moving now.
So on fourth month, we changed TAP Eprenol 25 milligram to TAP spironolactone 25 milligram. As per this is because patient can't afford the cost of cardiac drug. So we patient can't afford the cost. So we changed Eprenol to spironolactone. Fourth month after discharge, patient status. Patient was in NIHA class 2. Echo EF improved to 38%. Heart rate 74 per minute. BP 98/68 with the following drugs. TAP Army 100 milligram BD. TAP metoprolol exa 150 as BD dose. TAP Diator 10 milligram OD. TAP spironolactone 25 OD and digoxin 0.25 of 5/7 and TAP thyroxine 25 microgram OD and TAP ivabradine 5 milligram BD. And patient remained on close follow-up for 2 years. In the 2-year period, no major changes in clinical status. Still patient class 2. And he started working, and meantime he got married. He married so early because he already had an affair. And that time patient compliant severe painful gynecomastia, one of the common complication of spironolactone. So we changed spironolactone back to eprenol. Second admission after 2 years. Patient got admitted. The reason behind the admission was due to poor financial status, patient discontinued cardiac drugs, and due to severe depression, he consumed alcohol. So patient presented with paroxysmal nocturnal dyspnea and orthopnea. The heart rate 110 beats per minute and BP 90 to 68. That time the pro-BNP level 6,900 and echo revealed severe LV dysfunction, global hypokinesia, EF 18%, moderate MR. We managed patient with the IV Lasix and dobutamine for 1 day. Then beta blocker and Army restarted and up titrated. Advice, TAB Lasix 40 milligram, 40/20 as BD dose. Then TAB digoxin 0.25 milligram of 5/7. TAB eprenol 25 milligram increased BD dose. TAB eltroxin 25 microgram OD and TAB metoprolol succinate 50 milligram BD and TAB Army 100 BD. Improved symptomatically and discharged after a few days. At the time of discharge, improved to 30%. third admission after 4 years, that is February 2020. That time, patient admitted with the worsening signs of dyspnea, decreased urine output, cough with mucoid expectoration for 2 days, features suggestive of lower respiratory tract infection. As we know, one of the major precipitating factor for acute decompensated cardiac failure is respiratory tract infection. That time, serum creatinine 1.33 milligram per deciliter and pro-BNP 5,250. Echo, LV 70/62, septum 8/6, posterior wall 9/8, EF 20%, LA 45, AO 25, RVSP 40 plus RA, MR 2 plus. Patient was decongested with diuretics, IV antibiotics started, chest physiotherapy continued. In view of low BP, ARNI and beta blocker were down titrated and continued at lower tolerable dose as per hemodynamics. And in a stable state, we discharged patient. At the time of discharge, plan was to slowly escalate the dose of ARNI and beta blocker as tolerated by patient after waiting for a period at least 1 week before increasing any dose. Plan to initiate dapagliflozin on follow-up. Also plan to vaccinate him with pneumococcal and influenza vaccine on follow-up. The advice, tab Diato 10 milligram BD, tab digoxin 0.25 microgram of 5/7, Eplenon 25 milligram OD, Metlarexar 100 OD, and tab Eltroxin 25 microgram OD, tab ARNI 100 BD, and tab dapagliflozin 100 OD. Strict salt restriction, fluid restricted to 1 liter, and advice graded physical activity. In the last 1.5 year period, no major changes in clinical status. Patient still in class 2. He is able to work. He is continuing his work in media firm. He had a child. He is on regular follow-up with titration of drug in between. As per status June 2022, NIHA class 2, heart rate 68, BP 90/60, saturation 98, weight static 75 kg. Echo, LV 71/62, EF 36, LA 52, AO 25, global hypokinesia, MR 3 plus, TR 2 plus, mild PH. Presently, patient is on tab torsemide 10 OD, tab digoxin 0.25 milligram of OD, tab metoprolol 100 milligram BD, tab ivabradine 5 as BD is dose 5 and 2.5, tab eplenon 25 milligram OD, tab thyroxine 25 milligram OD, tab ARNI 100 milligram BD, and tab dapagliflozin 10 milligram OD. So before concluding, let me emphasize a certain point on heart failure management. Optimizing guideline-directed therapy is important. Close regular follow-up is another important aspect of heart failure management. Sticking on lifestyle modification should be ensured. Drug compliance, in addition to pharmacotherapy, vaccination, regular physical activity, etc., are important, especially for improving quality of life in patients with heart failure. Thank you.
Okay, Prerna, that's a very good case. So if we can start discussing this from the point where the patient was stabilized. So just start with the, I think, second or third slide where we stabilize the patient and he's been advised a heart transplant. The medication at that point, the absolutely almost the second, third, fourth slide somewhere. Go on to the first admission. Go to the absolutely first few slides. We'll take it up from there.
First slide.
Yeah, keep it here, keep it here. Fine. So basically, there's a patient who has come with acute heart failure, has been stabilized. His initial condition was quite bad. He was diagnosed as DCM At that time, he had both ischemic hepatitis and acute kidney injury. So he's gone through a very bad phase at that time, but he's stabilized. And then he gets readmitted in Sri Chitra and he's advised a heart transplant. So this quite often happens that the patient can be stabilized. Either you lose the patient during the first admission. If they stabilize, this first admission itself gives you a warning that if he was so bad that his kidneys got damaged, liver got damaged, that he's going to have subsequent events. So these patients have to be followed up very, very closely, and they should be told to rush to hospital before they come in such a bad shape again. So that is one thing. So he comes to Sri Chitra, is advised a possible heart transplant, further management. Go on to the next slide. Next slide. Yeah, so at this point, no, the previous slide was okay. The summary where you gave, previous one. Yeah,
stay
okay.
there, stay there.
Keep it here. Stay here now. So he's come with abdominal distension, basically right heart failure and left heart failure both occurring. And he has gross right-sided failure. So there's a lot of ascites, hepatomegaly. And at this point, his liver function is abnormal. Creatinine is also on the higher side. So see, if you look at these things at this point, besides managing the patient, you're also trying to prognosticate the patient. That supposing you do stabilize the patient again, is he going to come to you a third time, a fourth time, a fifth time? So here, everything is suggesting that he is in a bad shape. His right ventricle is also not helping him. So he's in right ventricular failure also, besides left ventricular failure. He has liver dysfunction, which is now becoming chronic. We don't know how much it was between the first and second admission, but now his liver enzymes are also rising. Normally, with heart failure, what happens is that they often develop jaundice, they look yellow, the bilirubin goes up, the liver enzymes stay reasonably okay for a long time. Moment you find liver enzymes also rising, you start getting worried that, look, this patient is not going to do well on medical therapy. Creatinine also rising, which is at 1.8. So 1.8 is alarming, but not sufficiently alarming to make you not think of the various forms of therapy which you subsequently do. He was found to be hypothyroid and thyroxine start. So as Dr. Krishnamurthy said, you have to look for reversible causes, whatever you can reverse. Look for iron deficiency, look at the ferritin levels. And there's no harm giving a bit of iron to most of these patients because they do have some amount of iron deficiency. We in fact found half our patients had iron deficiency even though the hemoglobin looked okay. So iron deficiency and thyroid function is very critical. Go on to the next slide. Go to the next slide, please. Next. Yeah, next. Yeah, keep it here. So the X-ray had shown just cardiomegaly. There was some plethora in the lungs. The ECG again was not very remarkable. As I said in the first case that you found that there was no evidence of AF or anything. So it was sinus rhythm. The ECG complexes were not very wide. So there was no left fundal branch mark. That means you could not think of any additional therapy from that point of view. EF as expected here is 22%, which is down. Now, what is important is that patient has severe RV hypokinesia. That means there is significant RV dysfunction. See, in this patient whom you're subsequently going to advise a heart transplant also, that means you're advising end-stage heart failure management. So end-stage heart failure management basically is either a transplant or an assist device. For a LV assist device, you want the right ventricular function to be normal. Because if the patient has severe RV dysfunction, then the LV assist device is not going to help in any way. It'll just improve the cardiac output from the LV side, but push it to the right ventricle, which can't take it. So patient will go into right-sided failure. So moment we have patient with end-stage heart failure, we look at two things. We look at the RV function. So if the RV function is normal, at least there is an option that a LV assist device, either a temporary assist device or a permanent assist device, might help him if he needs it. Second thing is he has TR, but there's no pulmonary artery hypertension. Pulmonary artery hypertension assessment is also very critical in these patients, because if they have significant pulmonary artery hypertension, which does not improve on therapy, then doing a heart transplant itself becomes a major issue, because a heart transplant in a patient with significant pulmonary artery hypertension becomes a high risk procedure. Generally, we would want in these patients to get the pulmonary artery pressure down or advise them a assist device in such a patient, or a heart-lung transplant, which are not very practical options for most of the patients. Even I have listed patients with severe PAH for heart-lung transplant. They never get to that point where they can have a heart-lung transplant. And actually doing transplants in patients with severe PAH creates a problem post-transplant. Many of them actually go into severe right ventricular failure immediately post-transplant. They have to go on ECMO. After that, it's just their luck. Some will make it, some will not make it. Because putting a patient on ECMO after a transplant is a difficult problem. So go on, next slide. Yeah. So this time the patient, this is his second admission now. He's been stabilized, was given diuretics, bolus, infusion. See here, this patient needed dobutamine as compared to the first patient. So obviously this patient is much sicker. Again, patients in acute heart failure who require dobutamine, the requirement of dobutamine itself is a negative prognostic marker. That means they require dobutamine, they require an inotrope to stabilize them. Then he's been correctly started on enalapril, changed to ARNI, beta blockers started. And then beta blockers could not be increased, so ivabradine started. Now, ivabradine is a very unique drug that it reduces the heart rate without affecting the LV function. So that way, and the benefit that is seen with ivabradine is that it reduces the subsequent hospitalization. It doesn't show much of mortality benefit, but it does improve the long-term prognosis in terms of reducing hospitalization. And here, where you're trying to grasp at straws and trying to do anything and everything possible, there is no harm in trying drugs like ivabradine. Though one thing is there, your title says ICU management. I would have preferred to, at this point, shift it to ward management, because ivabradine and beta blocker are drugs which we would prefer to start once the patient has gone off infusions and is stabilized. So we would only start drugs at that point. Go on to the next slide. Okay, CAT study done. So CAT study, whenever we present the data of a CAT study in a patient who's potentially being worked up for transplant, we would want to know the PA pressure and the PA wedge pressure, because you need to know what is called the transpulmonary gradient. If the PA pressure is normal, as was here on echo, and possibly the PVRI is normal, so it suggests that the PA pressure is likely to be normal. If the PA pressure is normal, you don't have to do many calculations. But if the PA pressure is high, then you have to be very careful and see whether this increase in PA pressure is reversible. You have to give drugs. You can sometimes give dobutamine, NTG infusions, or you can give an injection of sildenafil. Various options are there to show reversibility on the cath table in a patient who's being worked up for transplant. And subsequently, then you look at the other parameters. Now, in a patient who's potentially being worked up for transplant, interdepartmental consultations are also very important, because you want these patients to be in the loop initially itself with the nephrologist, with the gastroenterologist, the psychiatrist, and any other specialty where the patient will subsequently have to go post-transplant. So they are all involved in the pre-transplant workup, so that if there is something you miss, dental evaluation is also very critical in these patients. So all the things you would want to do pre-surgery. Next. So he's again now initially got dobutamine, again now he's levosimendan. So basically, on the whole, going through a very critical phase where he's getting multiple forms of infusions of inotropes. And the next thing is that beta blockers and ARNI had to be down titrated. This again is a bad prognostic marker that you're not able to give the recommended therapy and you're actually having to down titrate the therapy. Next. So due to financial constraints, not willing for transplant, after 45 days of hospitalization gets discharged. This is a usual problem because heart transplant is not a one-time surgery. It's a surgery followed by costly medications after that. Currently, if we see our own patients, we give an estimate of about 15 lakhs to the patient. But the idea is that with that amount of money, if he gets funding, many of our patients actually apply to the health ministry and they get funds from there. So we are able to do a full transplant surgery in about 1.5 lakhs because the hospital subsidizes many things. The rest of the money is actually used for buying medicines for that patient at subsidized rates and giving it to him each time that patient comes for a follow-up. So the normal bill of a patient post-transplant in the first 3 to 6 months will be almost 60,000 per month. So that's a pretty heavy amount which the patient has to pay. After 6 months, when he's off the antiviral and antifungal therapy, then the cost comes around 20,000 a month. So these are large amounts. And supposing during this time he gets a complication, gets a fulminant fungal infection, goes on liposomal amphotericin or crashes and goes on ECMO, those are add-on costs which need to be factored in. So financial constraint is a major problem. Generally, in a number of states, people are trying to pull in the government, or Tamil Nadu has some funds. I think even Karnataka has some funds provided by the health ministry for these patients, which vary from 10 to 15 lakhs. So that way, there are some funds available. So you need the social worker to be very active at this point to try and help the patient and guide the patient to various funding sources so that they can get the funds. Because the government does fund transplants, it doesn't fund LVAD. So you can sometimes get funds for these patients. So it takes some time. Next slide. So he's been discharged on a good amount of therapy. At this point, you could have added dapagliflozin, though that is a moot point. It can be added. Vaccinations and all. Probably this is the best time to give him vaccination. Next.
This was in 2016, so DAPA came later, that is why.
Yeah, I know. I was about to say maybe this is an older patient, so DAPA came much later. This is a very important point that should be brought out, that some drugs, the drugs are added as and when the evidence comes in. Maybe 5 years later, we'll be having the same quick case with Vericiguat also. So he's go on to the next slide. Yeah, so this checklist is very important. Most heart failure clinics have some kind of checklist. We also have a similar checklist, which is slightly different, but a checklist like this is very critical so that the nurses can follow the patient symptoms in a checklist and give it to the doctor when the patient is being seen. Next. Yeah, so these are parameters. He's at that point improving. His kidneys have improved. He has no ascites, so obviously his liver must have also improved. His weight is now 55 kg. And if you remember the last slide, his weight had become, I think, 75 kg. So either he's become overweight subsequently with the good management or whatever. We'll look at that later. Next. So his medication is being increased. Everything is being increased correctly. Next. Okay, so with that, his heart failure starts improving, ejection fraction also improves. And most of these patients, when they're well managed, the BP is in the range of 90 to 100. So if they have no symptoms of hypertension, that is fairly okay for most of these patients. Go on, next slide. So his continuing to improve. One thing is that if the patient has an ejection fraction, as long as it's less than 35%, we do advise an ICD implant. I mean, we don't want the patient thinking that advice was not given. Most of our patients don't get it because they can't afford it. Again, affordability becomes a major issue. But yes, as long as the EF is less than 35%, you should advise that as the guideline suggests, you should have a ICD if you can afford it. Next. So he's become okay. His EF has increased to 38%, and he's become NYHA class. He's going to subsequently worsen, but so let's go on to the next slides. So he gets married. That means his counseling was good, that he was told to do everything he wanted to do, gets married. Next. Now, this is critical. You have to emphasize to the patient that no matter what happens, continue the medication. As Dr. Harikrishna also showed in his presentation, that there is data that if you stop medication after stabilizing, the heart failure will recur, the ejection fraction will drop down again. So we do have studies suggesting that you cannot discontinue medications. And he's also started alcohol. So there's two clear reasons for worsening. Next. So again, this is what usually happens if you catch these patients early enough and you restart the medications, they do stabilize, but that is not a reason to stop medicine. They might not always stabilize when they've decompensated once. Next. So he's had another admission after 4 years, which is what is expected. See, overall, this patient was a sick patient. You do expect that he'll have multiple admissions. You don't expect that he'll be very stable on a long time. So again, worsen, again gets stabilized. This initial decompensation was with alcohol. This time the decompensation is with a chest infection. So each time a patient worsens, you have to search for a cause. First thing you do is have you continued your medicine? Have you stopped your medicine? Second thing is you always ask, do you have any fever, cough, expectoration? In ladies, is there any evidence of pregnancy or something else? Anemia is a major cause. And as in the previous one, alcohol was a major cause in that patient. And now with COVID vaccination or COVID itself can sometimes worsen these patients. COVID vaccine has also been found to cause problems once in a while. Next slide. So this is his fourth admission. By that time, I think the dapagliflozin data has come in. So he's started dapagliflozin. Vaccination, ideally, he should have got on his first shot, but in his first admission, by now, he should have been ready for his second pneumococcal vaccine. Here again, you have to understand that there are two pneumococcal vaccines. You have to give the polysaccharide and the Nemo 13 vaccine with a gap of some time. Next. So again, he has been advised multiple set of therapy, which are all good. Now he's also been advised graded physical activity. Next. So now this is now the sixth and 6.5 years. So he's now stabilized, which is very lucky for him because the initial presentation was quite bad. There is some data which suggests that patients who present in a fulminant way as what is called fulminant myocarditis, if they go through the acute phase, they recover very well. But he possibly may not have been exactly fulminant myocarditis because he kept worsening in the next 4 years. So he didn't exactly recover very well. So he's had a child also. Now, this is okay for a male patient, but if it's a female patient, it becomes a major issue for them when they get married. I've had a number of patients where they grew up. I was following them for 5 years, 6 years, 7 years. They grow up, get married. When they have children, then problems occur. They do decompensate. If they don't have children, then it becomes a problem for the family. I've had patients who actually had to end up with a divorce because they could not have a child because their function was down, and they were advised not to have a child. Next. So status June 2022, his BP is 90, weight has increased to 75. Here you have to see if his initial weight was around 58 or something. Is he gaining too much of weight because his improved ejection fraction is 36%? which is a reasonable ejection fraction. Most of the patients with an EF of 35% and above do fairly well if they're put on good adequate therapy. Though his LV is fairly dilated, 71 and 62. So it is possible that he's going to have another 1 or 2 decompensation if he does not follow up on the medications properly. Next time. So he's presently on all the possible drugs that you can think of. First line therapy is there, all the 4 pillars are there. Second line therapy also is there, so ivabradine is there. And what I call the third line of therapy, digoxin, is also there. So he's practically the best possible therapy that he can get in today's current medicine. At the most, you could think of adding Vericiguat when it comes to India, but I think it's just entered India. It's not in the market as such. They've just got the permissions to come to India. So DCGI permission has just come in. Next. Yeah. So what you have to always remember is that if you get a patient who's so sick, and even though you've advised a transplant, you know that one is they will not be able to afford. 2, even if you do list such a patient for a transplant, that does not stop you from continuing the rest of the therapy, because the patient has to survive till he gets a transplant. So it's very important to keep pushing up the therapy as and when possible and keeping an eye on the bad prognostic markers. For instance, this patient had every possible bad prognostic marker. He could not get up titration initially. He was having renal liver dysfunction. So all those were major issues, but they were reversing. So 6 years, for 6 years, he's just been going up and down on therapy. Currently, he's relatively stable. Along with that, he has to be counseled about self-management of heart failure. All those things have to be counseled to the patient and taught. And this patient, that way, he managed very well. He's managed to continue his normal life in the meantime. So I think we can have comments from Dr. Krishnamurthy and Hari Krishnan, then maybe take up some questions then.
Yeah, nice discussion. Just a couple of points. As you mentioned, our guidelines may change with time when more evidence comes about new drugs. So currently 2 more drugs have been studied and found useful. One is Vericiguat, the another is omecamtiv mecarbil. These 2 have been studied. They are not coming to guidelines, but they have been found to be useful. That is one. The other point to highlight is this patient was considered for transplant, and this patient has a few points in favor and some points against the considering transplant. One is the presence of pulmonary artery hypertension, which of course we are not studied. It is irreversible, but presence of pulmonary artery hypertension is not in favor of transplant. But there are 2 points also against. He has alcohol abuse, which is also considered to be a risk factor or should not be considered for transplant. But one positive aspect is that he is married and has got social support, which is considered very, very favorable. That is one. Another point I would like to just discuss is concept of advanced heart failure and end of life therapy for these patients. This patient is not at the stage of advanced heart failure, but when it comes to advanced heart failure, we should consider end of life consideration and should stop actively resuscitating when these patients are admitted. This is a little debatable. Hari Krishnan, please comment on this.
Yeah, I think this patient was not an alcoholic. Actually, he had that depression and he used to consume alcohol for some days. But after that, he recovered and he never used to. And we gave him, and he was telling me that he took only beer and he didn't take any alcohol. So that is, I think many of the people have a misconception that beer is not alcohol, and it is some like an energy drink or something. So I think this patient is an educated fellow. He was telling that I took only beer, I didn't take alcohol. So that is how, but that he got admitted at that point. So another point is that the maximum tolerated doses. This patient, we couldn't. You can see the drugs. The ARNI, the maximum, the recommended dose is 200 milligram BD, but never we could reach that dose. At 100 milligram BD, he used to get postural symptoms. So one way to assess these patients when they come for follow before the, when we want to uptitrate the drugs is to look for symptoms of postural hypotension, and also to see whether they have postural hypotension. So to take the BP in the sitting position and ask them to stand at 3 minutes to check the blood pressure to see any postural fault of more than 20 millimeter drop in the systolic blood pressure. So that you have to check every time you, because postural symptoms, they can fall and can have problems. So that we have to be careful. And in case you are not able to reach the recommended doses, you have to reach the maximum tolerated doses. There you will get the benefit equal to the recommended doses. That is what, even if you are not able to reach the maximum, you will get the same benefit if you reach at least 50% of the recommended doses. That is what the studies have shown. Sandeep, any other comments?
Yeah, I think Dr. Krishnamurthy also raised an important aspect of palliative care in heart failure. So that is a specialty which is coming up. We've also started looking at that. In fact, in a heart failure clinic, there's a resident from palliative care. We have a department of palliative medicine. So there is actually a resident from palliative medicine sitting there. The first step is that we are trying to assess the burden of heart failure symptoms and see how palliative care will fit in with our therapy paradigms. Because each time they come and discuss with us, I tell them, look, the concept of stopping all therapy, which is there in palliative care, is something which is not acceptable to us. And which is actually not the way how palliative care in heart failure works. The way it works in heart failure is that you are trying to reduce the symptoms and you accept that you can't do much for this patient, which means you will try to reduce the congestion. That means diuretics will continue. You will possibly remove drugs like beta blockers and ACE inhibitors. That means they let the BP go up slightly and allow a higher dose of diuretics to make the patient comfortable. Because this, once you talk about palliative care, these are patients who are lying down on bed, they're not moving around. You want them to be comfortable. Also, oral morphine is available. It's available on specific prescriptions. It is available with the centers where palliative medicine is there. So their prescriptions are honored, and they have the special places from where you can get oral morphine to reduce the symptoms of these patients. So this is, and plus that, along with that, you try and correct whatever else you can correct in terms of also giving them social support. Support not just to the patient, but also to the family, because the family knows that they're going to lose the patient. So all these are various aspects of palliative medicine which are gradually coming up. They've come up in the Western countries. Now gradually they will come up soon in India also. So I think, I don't see any questions in the chat box. So if there are any questions, we can have it.
We will go
so
to the
maybe
next.
we can go on to the next talk. The next talk is, I think, on behavioral therapy, which is a very important thing. Let's hear that talk now.
Yeah, I think the other topic will be dealt by Dr. Ritu. She is the scientist working in our Center of Excellence in Heart Failure. So we are now doing a trial on heart failure on cognitive behavioral therapy. So we have a program developed as part of the trial, and she is the person who has developed that. Over to Ritu for the presentation. Please go ahead, Ritu. We can hear it.
Good afternoon. Sir, am I audible?
Yeah, you're audible. Please go ahead.
Good afternoon. Today I'm going to present about the behavioral aspects in heart failure.
Yeah, please go ahead. We can hear you very well.
Mental health conditions are prevalent in patients with heart failure. Prior research suggests that these disorders lead to negative health and cardiovascular outcomes, and depression and anxiety disorders like generalized anxiety disorder, post-traumatic stress disorder are the common mental health conditions in heart failure patients. Depression also leads to poor drug and diet adherence. 1 out of 5 heart failure patient, 1 out of 5 heart failure patients have depression, and studies have suggested that a worst outcome in heart failure patients with depression across a broad range of events include mortality, readmission, and more use of healthcare and poor quality of life. Thus, in heart failure, depression can be regarded as a potential but a modifiable risk factor for impairment of quality of life. And depression in heart failure can be treated. However, adequate importance to care for depression is not, especially in our country. So let's talk about depression. What is depression? Depression means a feeling that lasts a few minutes, a mood that lasts a few hours or few days, or pervasive sadness of mood. Clinically, we can say that a condition that lasts 2 weeks that cause strong emotional suffering and makes it difficult for the patient to carry out daily activities. So patients with depression may also have symptoms of anxiety like heart beating fast, feeling suffocated, having chest pain, dizziness, trembling, bodily tension, and sensation of pins and needles all over the body. The patient may also report worrying all the time, thinking that something bad will happen to them, and avoid situations that make them feel anxious. If we see such a patient with all these symptoms, we can suspect depression. And how can we detect depression? There are many questionnaires that are available, and all these questionnaires are easy to administer and will take only less time. So I'm giving some of the examples there: generalized anxiety disorder questionnaires, the patient health questionnaire, Beck depression inventory, and cardiac depression scale. And these are commonly used. So here I'm showing questionnaire, that is generalized anxiety disorder questionnaire and patient health questionnaire, which we are using it in a trial. And the GAD-7 is used as a screening tool and severity measure for generalized anxiety disorder. The PHQ-9 helps us measure the symptoms of depression in each patient and decide whether the patient is on depression currently. What if it depicts a patient with depression? If we identify a patient with depression, first we should inform the treating physician or cardiologist. They will prescribe the medication for the patient. If the condition doesn't improve, the cardiologist will refer the patient for psychiatric consultation or for counseling. And we should do regular monitoring and follow-up of the patient when they visit our clinic. Next is the available treatment for depression. There is medication and psychotherapy. Antidepressants are given and as medication, and psychotherapy help is offered by talking to patient about their concerns and managing depression by helping people make changes in their behavior. Behavior therapy technique like cognitive behavior therapy is an effective treatment method for depression. So let's discuss about cognitive behavior therapy. What is CBT? CBT is a skill-based intervention specially designed to help patients to acquire skills and strategies to address the physical and emotional difficulties related to heart failure. So cognitive behavior therapy is a management strategy for tackling emotional problems. CBT is a treatment in which we learn how our thoughts and behavior influence the way we feel. This technique helps heart failure patients acquire skills and strategies to address the physical and emotional problems that often arise in the presence of a medical illness. How is CBT working? This therapy focuses on identifying, understanding, and changing thinking and behavior patterns that help change the way patient feels. The benefits of this therapy is usually seen in 3 to 4 months, and it depends on individuals also. This therapy provides a hands-on practical approach to problem solving. So how are we going to implement this therapy, or what are the goals of a behavior therapy? First is we help the patient cope with their physical health. Second is helping patient identify the dysfunctional thought. Third one is incorporating the positive thoughts to the patient. And fourth is encouraging to do activities or helping them learn to relax. So about the first, coping with the physical health. Advise the patient to make healthy choices such as quitting tobacco, eating healthy, and exercising. Next is compliance to treatment and lifestyle. Keeping the communication open with the doctor and the nurse is important. Monitoring and regular follow-up in the hospital. If symptoms are worsening or they identify unfamiliar or severe symptoms, ask the patient to seek medical consultation immediately. Identifying the dysfunctional thought. So dysfunctional thoughts are negative perceptions of ourselves, oneself, and about others. Studies have shown that significant relation between the frequency of dysfunctional thought and the severity of clinical symptoms. So here we are giving an example how we can help the patient identify their dysfunctional thought and help them bring to a positive or an alternative thought. So this is the situation of a patient. The situation is on patient's own words, like I was out of breath while walking in the ground with my friend. I'm feeling tired and sick. So this is the situation. The feeling that comes to the patient is feeling sad and depressed. So the immediate thought that comes to the patient mind is I'm always sick and nothing good is happening to me. So after giving the therapy, the patient will think alternatively, or another thought will come to the patient's mind. That is, although this is not a good news, I have faced similar challenges in the past. I need to think about what I can do to get better. So the third is positive thought and pleasant activities. So we'll guide the patient to do activities that help them feel better and solve problems. So we'll give a list of positive thoughts to the patient, ask the patient to give his or her own ideas about activities that are enjoyable to them. So some of the positive thoughts that we are giving to a patient is wear the dress they like. If they're interested in going out, they can go for an outing or go to a beach. They can meet their friends, watch their favorite movie, reading their favorite books, doing gardening, and use social media to chat with friends, and going to the place of worship. Fourth is positive activities or learning to relax. The purpose of relaxation exercise is to teach the body to be in a physically relaxed state that is incompatible with the feeling of worry, anxiety, or fear. So we are giving two types of relaxation exercises, that is breathing exercise and relaxation games. Breathing exercise includes, some examples are equal breathing, deep breathing, Brahmari, and butterfly hug. And relaxation exercise like snake and ladder and other indoor games like caroms. So here I am going to play two videos on breathing exercise. The first indoor games where we suggest patients to play caroms with their family members or friends. Next, conclusion. Behavior modifications are very simple and it can be explained to the patient by a trained nurse. Data suggests that improvement in heart failure outcomes like reduced readmission and better quality of life is seen when depression is addressed in heart failure patients. Thank you.
So that's a very good presentation. And these are aspects of heart failure management, which bring out the idea that you have to have a team management. So you have to have people who are looking at behavioral therapy, physical therapy, for things which the doctor is obviously not going to do. So you have to have trained people who can handle physical therapy and behavioral therapy and handle these aspects in encouraging the patient to actually live beyond his disease and to think that, okay, as you said rightly, that you were sick then, but you had fought similar illnesses in the past few months. Like the previous patient which was shown, for 6 years, he just kept going in and out of hospital. But in spite of that, he's got married, he had a child also, and then he's working in the media industry. So that can only happen if there's someone who's doing good behavioral therapy, talking and listening to the patient. And that is where the nurses have a very important role, because quite often the nurses are relatively less intimidating than the doctor who's very curt, most of us are very curt, very busy looking, and don't talk much to the patients. Whereas the nurses are actually would be knowing which patient is getting married, which patient is getting engaged, how many children each patient has. And that is how they are able to be good behavioral therapists for most of our patients. Do we have any comments from Dr. Krishnamurthy or Dr. Hari Krishnan? Any questions?
Yeah, I think this aspect is very, very important. I think as clinicians, we don't get much time to engage with the patient. I think the heart failure nurse is the key person who can do a lot of good to these patients. I think patients are more comfortable to interact with them, and they share their difficulties, their thoughts, all the issues related to the social aspects they share with our heart failure nurses, and they come to us and tell the problems, and we sometimes may be able to help in sometimes financial, so we can arrange some free drugs. All those things we are able to do. And behavioral aspects also, so many patients are diagnosed to have depression, have been referred to psychologists and psychiatrists, and some of them have a very good quality of life after treating the behavioral issues. And physical activity, that also, as I have already stressed, it is very, very important to have a regular graded physical activity which will improve the outcome of the patient or outlook of the patients to their life, so that they are more comfortable and they are more confident to do physical activity and do engage in their routine activities. They are afraid to go to places, afraid to go for an outing. So these aspects can be, they can give an they can be reassured that these activities are possible, and they have to be careful only, and always carry the medications with them, continue the regular medications, don't have a high salt intake, avoid alcohol. If you continue those things, they can have almost a normal social life, even if they are having a disease.
Just one point. Apart from the healthy diet, healthy or optimal sleep is also to be emphasized to them. Some of them are sleep deprived or they are not able to sleep. In that case, a sleep specialist should be consulted. Proper sleep is very important.
So do we have any questions?
I didn't see any questions no open questions.
Then we can maybe go on to the next talk. This is on the health education given to the patients by the nurses.
Ms. Rajita, our nursing officer in cardiology CC, will be presenting this talk.
We have to educate the patients with heart failure.
No, we can hear you. Please go ahead.
Significance of this program is actually heart failure causes the mortality, morbidity, and impaired quality of life. And also it is one of the leading cause of hospitalization. Most of readmissions occurs with these heart failure patients. These readmissions can increase the mortality, and also it affects the long-term prognosis of these patients. Research says that 1 in 4 heart failure patients are readmitted within 30 days. And this readmission burden on the individual, family, and also the healthcare system. What is the reason for this readmission? The main reason one is lack of patient compliance to drug, to the diet, and also to the follow-up. If there is an inadequate discharge preparation and education, and it can also lead to readmissions. Then the identify residual congestion. Actually, these ADHF patients will have a residual congestion within 7 to 10 days of hospitalization. And this is one of the most important factors for readmissions. If the patients have a delayed discharge follow-up, it can also cause a readmission. For this, we have to emphasize that these patients need to be followed up within 7 to 10 days after discharge. And if there is a poor communication between healthcare providers, as all you know, in COVID situation, most of the patients are reluctant to go to hospitals. If we have a good peripheral health system, then they can utilize that, and also we can help these patients. There are certain areas that patient needs to be educated. First is the basic information regarding the heart failure, and some worsening signs are there of heart failures. They have to identify and come to the hospital immediately. And certain modifications of their lifestyles like diet, exercise, their risk factor modification, and also depression and anxiety, they have to manage, and we have to train these persons to manage this depression and anxiety. And they have to go a strict compliance with the drug therapy and also regular follow-up. So what area the patient should know about heart failure? They have to know what is heart failure and what are the types of heart failure, what are the signs and symptoms that can develop with them. And they have a doubt that whether it can be treated or controlled, and we have to ensure and we have to explain the treatment modality also. And also we have to explain them the prognosis of their disease. These are the certain warning signs of heart failure that indicates that their clinical status is worsening. They have already dyspnea, fatigue, and palpitation. If these symptoms are worsened, they have to immediately come to the hospital. If they gain the weight more than 2 to 3 kg in a week, it's an indication of their worsened clinical status. So they have to report immediately. They have to check the urine output. If there is a decreasing in urine output, it's a worsening clinical status. And also, if the patient have an irregular, rapid heartbeat, sometimes with shortness of breath and chest pain, sometimes they faint, that also shows a worsened clinical status. And sometimes the patient develops a new symptoms like orthopnea and paroxysmal nocturnal dyspnea. They have to come to the hospital immediately. There are certain lifestyle modifications we have to teach them, and the heart failure team has the responsibility to modify their diet, exercise. They have to train their to deal with their depression, anxiety, and also risk factor modification. We can move on to the diet regimen for these patients. The diet should include salt and fluid intake restrictions. Salt and fluid restrictions are indicated only in patients with congestion. If a patient is not in a congestion and also in a very stable condition, the salt and fluid restriction is not indicated. And they can have salt intake 2 to 3 grams a day, and fluid is restricted to 1.5 liters a day. And they have to avoid excess calories and follow a healthy heart diet. They can include more of fruits and vegetables in their food, and mainly non-starchy vegetables. Why sodium restriction in their diet? This sodium can reduce they can control their blood pressure, they can reduce the edema, and also they can reduce the breathing difficulties. So sodium should be in 2 to 3 grams a day. And we have to teach them to read the food labels, because we can choose a low salty foods after reading these food labels. And then also we have to avoid canned foods. The fluid intake, most of the patients think that the fluid restrictions is only for the water, but the fluid intake should contain all the watery contents of foods like coffee, tea, some fruit like watermelon, ice cubes, soup, then ice cream and jello, juice and water. All this comes in the fluid intake. So they have to think about the fluid intake. They have to follow the doctor's instruction. What about their restrictions? And because we have to teach them that too much of fluid can make their heart congested. They have to increase. They have to take a heart healthy diet. It should contain a low fat, low cholesterol, and a high fiber diet. Plenty of fresh fruits and vegetables should needs, and they have to avoid alcohol. As all you know, alcohol can increases the blood pressure, and also it can increases the myocardial toxicity. It's an important thing that they have to maintain a healthy body weight. So that for that they have to check their weight every day in the same time, mainly at the morning time. And they have to keep a daily log of their weight. The important thing is the exercise, and we can add the exercises according to their physical ability. and it can improve their outcomes and also reduces the symptoms and also it improves the functional capacity of the heart. And these exercises can reduce the risk of hospitalization or rehospitalization by improving their reducing their symptoms and improving their physical status.
Slides are not moving.
We have to do regular exercises with a moderate. Is it moving now?
No, it is in the diet only. It's still in the diet.
So now it's moving.
Yeah, go ahead.
So regarding their body weight, they have to check the body weight every day using the same scale at the same time in the every morning, and they have to keep a daily log of their weight. Next is the exercises. We can add a graded activity or exercises that can improve their outcome, that can reduce their symptoms and also improve the functional capacity of the heart. And it reduces the risk of hospitalization. So we have to encourage them to do regular exercises with moderate intensity, depending on their physical ability. And aerobic and weight training exercises both are useful for these patients. This is a walking exercises. They can walk for 20 to 30 minutes a day, actually 5 days a week. They can start in a 5 to 10 minutes a day at a slow pace, and they can add the time and speed as the patient gets stronger. And also they can, during walking, they should be able to talk. And if they feel a shortness of breath, they can stop for 1 to 3 minutes and start walking again at the slower pace. It's an example of torso stretch. They have to stand straight, fold their one arm behind their head. They have to hold the elbow of the other arm, and bend the body towards one side and vice versa. This is another example of torso twist. It's a stretching type of exercise. They can sit in the chair and face forward. They can place both hands behind the head with their elbows out to the side and slowly twist the torso to one side and hold the position for 10 to 30 seconds and repeat on to the other side. This is another seated march. First, they have to lift the left leg with the knee bend, then as far as they're comfortable. And then place the foot down with control. They have to repeat the with right leg, and we can do with the each leg. Another exercise is training. Weight should not exceed 1 kg. We can use 1 liter of water bottles in both hands. And they have to do the arm weight exercises. Another area of health education is drugs. They have to do strict compliance on drug therapy. We have to explain why these drugs are for them, when they have to take, how this acts, and what are the complications and what they have to do with when they comes with these symptoms. So AC inhibitors, as you all know, they are captopril, lisinopril, enalapril, and ramipril. ARBs are losartan, valsartan, and olmesartan. ARNIs are sacubitril, valsartan, commercially available as Vimada and Asmada. And we are not administered these ARNI drugs within 36 hours of switching from OR to an AC inhibitors. One of the main complications the patients develops is persistent dry cough with these drugs due to increased production of bradykinin. They have to contact the hospital or to the doctor immediately if they have a dry persistent cough. And it can cause hyperkalemia, so they have to monitor their serum electrolytes, mainly potassium and creatinine values in every month. Then angioedema is another complication. Then hypotension, postural hypertension. When we have to teach these patients to measures to avoid orthostatic hypotension. When they are getting from the bed, they have to sit for some time, then only they can stand and walk. And when they climb the stairs, they have to hold the railings. There is another drug of choice is beta blockers. They are atenolol, bisoprolol, metoprolol, and propranolol. So when they come to the follow-up or before, during therapy, before initiating or uptitrating the therapy, we have to look for the heart rate and BP, mainly the postural BP. First check the BP, then they have to stand for 3 minutes and check the BP. If there is a marked difference of 20 millimeters of mercury, then we have to be cautiously increase or initiate or uptitrate the therapy. Then patients with a history of asthma can sometimes worsen in rare situations only. And before starting or they are taking beta blockers, we have to teach how to check their pulse rate. And if it is below 50, they have to come to the hospital. And we must explain them, do not stop this drug suddenly. It can cause hypertension, tachycardia, sometimes angina also. Nowadays, beta blockers we are giving to these patients with extended release forms, and these drugs should not be never crushed and taken. Another drug is aldosterone antagonist. They are spironolactone and eplerenone. For this, it can increases the potassium in the blood, so they have to check the serum potassium, blood urea nitrogen, and creatinine levels. If patient is taking an ACE inhibitor, we have to also assess the signs of renal insufficiency. If there is, we have to use it cautiously. The other drug is sodium glucose co-transporter 2. That mainly nowadays we are giving as dapagliflozin, and this is the backbone therapy for patients with chronic stage C heart failure with reduced ejection fraction. As it causes glycosuria and it causes increased microbial growth and causes urinary tract infections, mainly necrotizing fasciitis of the perineum. So perineal care, we have to teach these patients the importance of perineal care. Then can cause polyuria and causes this dehydration and orthostatic hypotension. So features of hyponatremia and orthostatic hypotension we must emphasize to these patients. Another drug of choice is diuretics. Patients with diuretics should monitor their weight and they have to monitor their intake output and serum electrolyte levels. Some diuretics like thiazide or thiazide-like diuretics can cause hyponatremia. So we must assess the signs and symptoms of hyponatremia and also teach these symptoms to these patients. Monitor blood glucose levels because some agents can cause hyperglycemia. They have to check their blood urea nitrogen and creatinine levels regularly. And as previous speaker told that administer diuretics in the daytime to prevent the nocturia, mainly at the 7 a.m. and 3 p.m. And Lasix bolus we should not give as a bolus dose because it can cause autotoxicity. It should be given as a slowly over 5 minutes. This is one of the most important thing in heart failure management, that is follow-up. Follow-up can reduce the rates of rehospitalization and also regular follow-up improves the outcomes in patients. The first follow-up should be within 7 to 10 days after discharge. During the follow-up period, we have to emphasize, reinforce their diet and physical activity. We can assess their physical condition and increases the exercises in the follow-up period. And during follow-up, we have to check the heart rate and also the postural BP before hiking any medications, mainly beta blockers and ACE inhibitors. Then they have to come to the follow-up period with the weight monitoring, weight log, so that we can check their weight pattern, and also if there is any increased weight, that we can titrate the drug, and also we can increase the health education to these patients. We have to strictly ensure drug compliance during the follow-up period. And also we can use these newer technologies for telemedicine technologies for monitoring drug compliance of these patients. And during the follow-up, we are up-titrating the drugs. And also we have to ensure a regular follow-up of these patients. As a conclusion, this health education to these heart failure patients helps to cope with the disease. They can manage their risk factors, they can adopt a smart, healthy diet, and also they can manage body weight. And we can, with this health education, they can balance their physical activity with safety. Helps to adhere with drug therapy, and also this will improve this quality of life. Thank you.
Thank you. That was a very good presentation. So in fact, a very good summary of the entire symposium today. So these are the things which nurses have to understand when they're managing patients with heart failure, the things they have to give advice on various aspects. So it's not just teaching them about the various drugs and their side effects, but also going beyond drugs, talking about physical activity, relaxation, diet. So all those things have been very well covered. In fact, should be circulated to all the participants. That's a very good set of summary slides. So if we can now conclude, and Dr. Krishnamurthy and Dr. Harikrishnan can then give the final comments.
We had a very good discussion, a lot of interaction also. And that is a very nice roundup. I don't have any further comments.
Yeah, I think it was a very useful session. I think we have received some comments in the chat box also that the session was very useful, and we should have more sessions. And I should especially thank Dr. Sandeep Seth for that wonderful discussion he did with each of the cases, and the point by point discussion on the different aspects of care, starting from titration, assessing the patient, to working up the patient for a heart transplant. So when we initiated the program, I had in mind Dr. Sandeep, because we have done many programs for the nurses, because Heart Failure Association, all the nurses programs are handled by Dr. Sandeep, and he is the best person to do such a wonderful presentation and a discussion. So thanks to Sandeep for joining us and having that great discussion. Thank you so much. And now it is over to Sister Leena for the conclusion. Yeah, please. We can see your slides, please.
Good afternoon to all. Now it is time to conclude our program. What we have seen is heart failure is a chronic progressive disease in which heart muscles fails to pump enough blood to meet our body's needs for blood and oxygen. Person become unaware of the disease in the initial stage as our body's compensatory mechanism masks the symptoms. But as disease progresses, he feels difficulties, but by that time, he may be having other comorbidities like diabetes, hypertension, renal diseases, and the treatment become more complex. So early diagnosis and treatment of heart failure is very, very important. All the presentations were good and informative. Good case presentations give us an insight into how we can manage these patients with heart failure. Lifestyle changes, medications, device and surgical procedures, and ongoing care are very, very important in the treatment of heart failure. Cardiac rehabilitation will help the patient to stabilize, slow, and reverse the progression of the heart failure. It includes continuous medical evaluation, physical exercise programs, counseling, support and training to return to normal life or to work, and counseling to modify diet. A multidisciplinary approach is very important in treating these patients. A good teamwork can effectively communicate, and we can help these patients to improve their quality of life. The team must include a heart failure specialist, cardiac surgeon, cardiac specialist, palliative care physician, primary care physician, heart failure nurse, pharmacist, social worker, physiotherapist, occupational therapist, and a dietitian. The SCT-IMST had a super specialty hospital in cardiology, and it is a national center of excellence established by ICMR for advanced research in heart failure. We have a heart failure registry and a heart failure ICU. India's first heart failure biobank is in our hospital. Many research studies are going on in this center under Professor Harikrishnan, which will certainly add on to the care of patients in future. Today, we are blessed with the presence of our director, Professor Sanjay Bihari. Sir inaugurated our program and motivated us. On behalf of the whole team, we thank you, sir. We are lucky to have eminent professors in cardiology to chair our sections. The whole team thank each one of you, sirs. Your contribution enriched the program and made it so lively. Grateful to you all, sir. Professor Hari Krishnan, the President of Heart Failure Association of India, is the brain behind this webinar. And we thank you, sir, for all support and guidance given to us to conduct this webinar. Thank you, sir. I take this opportunity to thank our nursing superintendent, Mrs. Nirmala, for giving all support to us. Thank you, ma'am. We congratulate and thank all the presenters who put effort for the success of this program. Thank you all. We thank all those who attended the program. We hope the knowledge shared will help and motivate those who care patients with heart failure. Now we are coming to wind up the program. And once again, thanking you all. Have a nice day. Thank you.
Thank you once again, everyone, for that nice session. I think please, those participants, please send your comments how to improve our program so that we can do our program better next time. So please send your suggestions how to improve the program. So that is very, very important. So what are any sessions which we have missed? So whether you wanted to discuss something more, so something, some areas where we have missed, please inform us so that we can, when we do the program next time, we will do it better. So thank you so much once again for joining. Once again, thanks to Dr. Sandeep Seth and all the participants who joined. Thank you.
Thanks,
Sandeep,
Dr. Hari.
My personal
For the
behalf
wonderful
also, thank you.
session. Thank you. Have a nice weekend.
Thank you. Thank you.
Thank you.